Good morning, good afternoon, or good evening. It's really my pleasure to start this WHO 4th Infodemic Management Conference. I'm Dr. Sylvie Briand. I'm the director of the Global Infectious Hazard Preparedness at WHO in Geneva. It has been nearly a year since the first Infodemic Management Conference, where WHO virtually convened experts from around the world to develop a global framework for this growing discipline. So much has happened since then for advancing infodemic management. We created the new scientific discipline of infodemiology, bringing together scientists from several scientific fields in order to develop the evidence needed to better manage infodemic. We have now a research agenda with the priority question to address. We have developed a workforce to translate infodemic management into concrete action. 263 people in 73 countries have been trained in 2020, and we are applying for a second cohort in 2021. We have developed strong partnerships with other UN agencies and technical partners like US CDC and ECDC. We have now a collective service with UNICEF and AFRO. We have also a strong partnership with UNESCO and the UN Global Pulse. The call to action that was issued in December 2020 brought together various segments of the society. And in response to our call to action to invest in infodemic management, there has been an extraordinary diversification of research tools and techniques. There is more and more awareness of the importance of managing infodemic among governments and health authorities. It is more and more seen as a necessary public health intervention, as important as vaccine or therapeutics to control an outbreak. This conference is a continuation of our earlier work and also the first of what I hope will be many more meetings and of great minds to continue this series. Sparkling new collaboration, sharing new tools for infodemic manager toolbox, and sharing lessons learned and practical techniques that countries can use to help strengthen the COVID-19 response and strengthen also the response more broadly. Since the beginning of the pandemic, we gained a better understanding of the 4 key activities that are needed to manage infodemic. First, we need to listen to populations' concern. Second, we need to communicate risk and distill science. Third, we need to promote resilience to misinformation. And fourth, we need to engage and empower communities. Listening is the critical first step for any public health team to inform their decision-making. We need to hear people's voice to better understand their needs, to respond more effectively, and to build trust. As you all know, trust is absolutely essential to respond to epidemics and pandemics. We have qualified the infodemic as a tsunami of information, some accurate, some not, that comes along with a disease outbreak. So social listening during pandemic is challenging, because we are confronted to a cacophony of signals. But there are 3 things that are really important with listening. First, it needs to be a real listening, without preconceptions and with empathy, to recognize what really matters for the population. We need to have pertinent analysis of the content, and for this it is critical to develop frameworks to separate signal from noise, to detect rumors as they emerge, and to make sense of trends. Of course, our aim is to improve our listening to the point of being proactive instead of reactive, and being able to anticipate rumors and prevent their amplifications. And last but not least, this active listening should also be translated into action to protect health. Social listening cannot be limited to the content of the conversation. It should encompass information and emotion. Of course, it is complex, but it is also crucial. And this is why we are together today. We need to continue to progress and improve the communication ecosystem in which we are in. Through this conference series, we hope to spark new collaboration and continue to strengthen coordination initiatives because we, the whole, is truly greater than the sum of its parts. And I'm delighted that partners in public health, including US CDC, ECDC, Collective Service, UN Global Pulse, are here with us today. And I warmly welcome all of you, experts and learners alike, to join us in solidarity to champion advances in social listening for public health. And thank you very much for your attention. It's my pleasure now to introduce Elisabeth Wilhelm from the US Centers for Disease Control and Prevention to say a few words. Liz, floor is yours. Thank you.
Thank you, Dr. Briand. Good morning, afternoon, and evening. Thank you for the opportunity to address colleagues working in infodemic management around the world. The last year has been especially hard for many of us who work in public health. The COVID-19 pandemic has highlighted the gaps in our health systems and underscored the importance of investing in preparedness and surveillance, not just for pathogens, but against misinformation. In emergencies, our brains operate differently, and that altered thinking influences how we take on information and respond. In a crisis, we search for new information, have trouble taking in and digesting complex information, and we tend to believe the first thing we hear. Science is moving at a blazing fast speed, but so does emotionally charged misinformation. This has proven a challenge for many of us working with the virus and the infodemic simultaneously. In the past year, I have marked time by engagement in the WHO Infodemiology and Infodemic Management conferences. I was working with UNICEF in Indonesia last March and working with civil society organization Mafindo to take on their greatest challenge, address the spiraling infodemic that accompanied the first COVID-19 cases that came to Indonesia's shores. Making hoax busting or misinformation management a central piece of the public communication strategy took a lot of late nights, troubleshooting and website development at frantic speed with colleagues in government, with Mafindo and UNICEF, even as Jakarta started movement restrictions and offices emptied and Zoom calls became a daily feature. In this moment, the first WHO Misinformation Focus Conference took place. That's where I met Tina Pernat and got to know many of you. A year ago, I knew that my day job, building vaccine acceptance and demand globally at US Centers for Disease Control, would inevitably intersect with this new area of infodemic management. Here we are, a world much changed from a year ago, but with renewed commitment to build a better health system that addresses everyone's information needs and supports an ecosystem that protects and nurtures people's health. Since last April, US CDC has blossomed into supporting WHO in the June 2020 Infodemiology Conference, and in November, the first Infodemic Manager Training. This year, we launched our own insights unit at US CDC to better address COVID-19 vaccine misinformation, and I hope that's just the start. All of this makes me hopeful that as we have built a cadre of infodemic managers in 2020 and in early 2021 to shape the course of the pandemic in the coming year. WHO's leadership role in this space has been dazzling to see, and I hope to continue seeing more and more infodemic management work and trainings and conferences and opportunities to build back better in 2023. Thank you to all of you for your continued partnership, and I wish you all an inspiring conference that marks a year of advancement in infodemic management. I wish you a wonderful series of sessions today. Thank you.
Thank you very much, Liz. Now I would like to introduce Tina Pernat, who has kindly agreed to be our moderator today and to share her thoughts. Tina, the floor is yours.
Thank you, Sylvie, very much. It's really an honor to moderate today's conference, fourth in line. And I too have actually been counting and measuring time over the last year and a half by the conferences. So I find these exchanges of expertise and experience really, really important, because I think we've all, from all of our perspectives and our everyday work challenges and day jobs, really learned that we do need to come together. We're pushed to really do interdisciplinary work based on evidence, supported by infodemic evidence and toolkits that we're developing together. So it's really an honor to moderate today. I will follow the model of both Dr. Viroy from Ministry of Health Thailand and Dr. Neville Kalea from Ministry of Health Malta, who have helped us last year as a community to really come together to define both the research agenda and what we can do together as a society, as Sylvie kindly framed. I really think that today is a first example really of a deep dive of us into a more technical exchange of experience from a variety of speakers. It's quite a packed agenda, so I will actually stop now to get some housekeeping. And before I do, just to note that today I'm participating as in personal capacity as an expert, someone that really lives for the development of the infodemic management practice and the science. My today's views do not represent views of ECDC, so I'm really honored that I can participate and support the unicorn community going forward. So, Chris, you have some housekeeping items so that you can keep us in check.
Great. Thank you very much, Tina. So I'll bring up the slides here. Very warm welcome to everyone who's joining us here today for the 4th WHO Infodemic Management Conference, Advances in Social Listening for Public Health. And you can see here there's a link for the conference landing page where you're able to register for the next days as well. Warmly welcome everyone to use these hashtags, Infodemic and Infodemic Manager, to share the lessons learned today. And flagging up that today we're really focused on case studies applying social listening for public health. And the second day will be a deeper dive into the tools and techniques for listening to communities to strengthen health systems on the 11th of May. And then our third and final day of the conference on 12th of May will be a panel discussion digging into the deeper issues, challenges, and opportunities to advance social listening in public health. So please make sure to claim your spot because there are limited spaces for the Zoom where you can participate in the live Q&A. So I want to do a little bit of an overview of the objectives of the conference. And I've already shared the ability to register for the next days. And also note to everyone that there is the interpretation option available. So in the Zoom, you're able to toggle to a different room if you wish to hear the event today in French. We are also warmly welcoming your questions in real time as we are going through these wonderful speakers, their presentation. So please remember to post your questions in the Q&A box in Zoom, and those will be gathered up and shared with the speakers. And this meeting, I want to reemphasize that it is being live streamed and recorded, and it will become available on the EpiWin WHO YouTube channel, and you can subscribe to that using the link you see here. And in a moment, I'm also going to cover a quick declaration of interests, so we're all on the same page about the participants. And again, warmly welcome sharing of the exciting lessons learned here today on social media using the Infodemic and Infodemic Manager hashtags. So I think we're all on the same page, having gathered for this event on social listening about the need to have an evidence-based framework for infodemic management, of which social listening is a really important part, right from the monitoring phase of the infodemic, looking at the infodemic curve here to inform the response, right through the evaluation phase to help adapt the response in real time to the changing needs of communities. And in terms of the goals of this specific conference here today, we're really keen to spotlight the case studies that we're seeing coming out of the regional teams, country teams, from our partners, and from here at WHO HQ to help facilitate knowledge exchange and keep strengthening collaboration. And we're also really keen, and this will come into play in particular for day 2, we're keen to identify best practices and tools for social listening and network analysis so we can work on improving our capacities for generating actionable insights that are going to help public health decision makers better tailor activities for maximum impact and return on investment. And of course, the goal here is to apply social listening advances to strengthen public health initiatives and coordination and feed into the development of the WHO social listening guidance and training that is underway and really identify new opportunities to build capacities for greater preparedness for new and resurgent health threats. So now touching on the declaration of interests, these are listed in alphabetical order. I wanted to flag up quickly here that we have Carl Aberer participating in the conference from Linkalong, and he is a company co-owner with 50% ownership, so noting that. Also, we have Claudia Day joining us today, a senior account manager for the Pulsar platform company, who will be a part of Isabelle's presentation. Matthew King. He's a co-founder of the Murmuret Company and is producing work on misinformation as a commercial entity. He'll be joining us on day 2. Srijan Kumar from the Georgia Institute of Technology, also participating on the panel, has received research grants, including from Facebook. His research group received a research gift to him as the PI and Professor Polo Chow, a co-PI, to conduct research on adversarial machine learning models. Also, a research gift was given to the Georgia Institute of Technology, listing him as the PI. Rory Smith will be joining, and he'll be sharing some more about tools that are available for social listening. This will be day 2. He's a research manager at First Draft News, which notably has received grants from Facebook. Harry Wilson, he's a full-time employee of the City Beats company, which is under contract with WHO. Amy Wright and Paolo Vaca, they are both full-time employees of the Media Measurement Company, which is also under contract with WHO. So with that declaration, I want to quickly orientate us to the agenda for today. So we're all on the same page. We've got an action-packed agenda with lots to happen. And to help orientate us here, we're going to have a series of talks in batches, after which we'll have about 10 minutes Q&A. So each talk is to be no more than 10 minutes. We will flag up a 9-minute warning, so you know you can wrap up quickly. And then once we've had several talks, we will have a 10-minute Q&A session. So we actually encourage everyone to share your questions in the Q&A box in the Zoom while you're listening to the presentations, so we can be gathering those up during the presentations to share for the Q&A. And so our agenda here today, we have a second batch of talks followed by a Q&A, and a third followed by a Q&A, after which point we will have a keynote from Ms. Jess Collis from the US CDC, followed by a final Q&A with some concluding remarks from Ms. Pernat. So that's the agenda, and flagging up again, make sure you claim your spot for day 2 for the conference, and also for day 3, and the team will share the links here in the chat so you have easy access to them because there are limited spots available. So thanks very much for your attention and for joining us here today. And with that, I will turn it back over to you, Tina.
Thank you, Chris. This is really good overview. It is quite a packed agenda, so I'm pleased we're a bit early, and let's see if we can keep on that. The first session that we are going to discuss is actually from our colleagues from WPRO regions, and actually I would wish a good evening to Jun Ryan Orbina and Shereen Ayub from the WPRO Philippine Country Office and the Western Pacific Regional Office. So I would invite them to share a screen for the presentation. And they will be speaking about their experience with the country case study on social listening. Please, welcome and good evening.
Thank you so much, Tina. Good morning, good afternoon, evening to everyone, wherever you are. As Tina mentioned, I would be greeting you from this part of the world in the Western Pacific region. My name is Shereen Ayub, and I'm a risk communication consultant with WHO Western Pacific region, otherwise known as WPRO. And today I'm joined by my colleague, Jun Orbina, as Tina mentioned, who is Communications Officer with the WHO Philippines Country Office. So this session today is divided into two parts. Firstly, I will provide an overview of how WPRO has been utilizing social listening tools for public health. Then I will pass the mic to Jun, who will provide a case study on how social listening has been used at the country level in the Philippines during the COVID-19 pandemic. Jun and I are excited to be here today, and we hope our insights may be helpful to your context. So there's a lot of text here in a limited amount of time, but the point here is that we have seen that the use of social listening has expanded both at the regional and country levels since 2005. There was a scale up across the region in terms of social listening strategies and systems. Here's a mapping of how the region has been building capacities in social listening to leverage ground sensing, not only during COVID-19, but we hope to see this beyond the pandemic and be something more sustainable. What you see here is the overall strategy that's been applied in the region, starting from identifying and leveraging manual social listening tools and building off of each additional tool to optimize the larger system. Optimization includes use of perception surveys and working with partners like local NGOs or social media companies. And during the COVID-19 pandemic, most countries adapted the plans that they had already developed or were continuing to develop and applied it specifically to respond to the COVID-19 emergency. While that mapping is much more conceptual, we do have examples of more tangible products and results from using social listening. There are many examples, both offline and online, but I'll use the example here of how social listening findings supported in the development of targeted COVID-19 messaging that were then broadcast on WPRO social media platforms. What you see is the strengthening of dynamic listening through manual listening and social listening software, supported in really hearing conversations happening at the country levels across the region, listening to the conversations that people were having on transmission, protective measures, NPIs, you name it, and then production of our health promotional materials incorporated these nuanced on-the-ground insights. Some quick lessons that had been learned. Social listening can be extremely useful in guiding a public health response. And yes, I think we all are here with that same sort of agreement. And it's helped us in digging up messaging from communities to better inform the work we do as strategic communications specialists. That being said, countries can benefit from listening to their communities more, whatever method that may be, offline, online, in order to better identify certain knowledge, attitudes, and behaviors at the ground level. Partnerships can be extremely helpful, whether that's with tech companies or local NGOs who can help with more offline listening. And lastly, something is better than nothing. And I really want that to resonate. We have found that it's not completely necessary to overhaul everything you have now in terms of social listening tools and spend a lot of time creating a new system. Whatever you already have now, especially in times of an emergency, even if that's just periodic manual listening, that's still a core tool. Use that and do what you can and build from there when the capacity is available. So that's an incredibly quick snapshot of what's been going on in the region. But now I will turn the mic to my colleague Jun, who is based in the WHO Philippines office and can speak more on the country level experience. Jun, over to you.
Thank you very much, Shereen, and good afternoon, good morning, good evening to everyone. In the Philippines, the WHO Country Office has been supporting the Department of Health, or the DOH, in multi-source listening, particularly in online listening. The weekly insights gathered from online listening are analyzed with insights from other sources from the DOH side, such as media monitoring, pulse and surveys, chatbot and hotline queries, and community conversations. Listening has been particularly important in the COVID-19 vaccine rollout in the Philippines because some of you might know that we are in a highly politicized context, and the perceptions on new vaccines are heavily influenced by the country's recent experience with the dengue vaccine rollout. So at the start of the year, we supported DOH, or since the start of the year, we have been supporting DOH in monitoring how our desired COVID-19 pre-rollout messages, the ones you would see in light blue bars here, were cutting across other chatter on COVID-19 vaccines, which are in dark blue bars shown in the slide. These were measured on the DOH Facebook page, which currently has 7.6 million followers. Each bar represents a conversation theme, and the length of the bars represents the volume of interactions. So DOH has been using social listening insights in developing and publishing compelling online content, and we have been seeing how pre-rollout messages were also rising in prominence among other online conversation topics. Subsequently, we have been seeing an increase in the share of voice of the DOH Facebook page as a primary or central source of information for COVID-19 vaccines. Next, please. Social listening is also being used to monitor rumors, misinformation, and disinformation. And we will share with you an early example which has somehow set the tone on the manner of how we respond to future or to subsequent rumors. Earlier this January 2021, we have detected the recirculation of a year-old that was January 2020 news on mask use. This contained old advice limiting the use of masks to health workers and those with symptoms. WHO recommendations on mask use, as we know, have been updated last August 2020. The reposting of old news has created confusion with those who have read the post without checking the date. And the old recommendations were also not aligned with the local guidelines. So to some, the news fuels further skepticism towards health authorities such as WHO at such a crucial time where people are looking for trusted organizations for information on COVID-19 vaccines. Next, please. So using available tools, we sought to understand the situation by determining the spread of the reposted news and the conversations on pages which did the reposting. And seeing the limited spread on the number of pages and the kind of pages, we have decided on a more conservative approach rather than a direct reactive messaging from WHO Philippines. The latter could have driven further attention to the mis or disinformation. Next slide. So what we did was we instead commented on individual pages which reposted the news and highlighting the date of the news and pointing the conversation to updated and official mask guidance from WHO. And some of the pages immediately took their posts down. We also coordinated with a media outlet, which was the source of the old news. The outlet promptly updated the social media version of the original post, indicating that the article is a year old. And we have also increased messaging and proper mask use on the WHO Philippines social media channels. There were no further spread and news pickups 24 hours after the interventions. So this is early example of the cycle that we have been using of listening, understanding, deciding on our action, engaging and monitoring, and back to listening has been useful as we continue to address rumors, misinformation, and disinformation. At present, WHO Philippines continues to support our colleagues at the Department of Health for social listening in shaping online conversations, in rumor monitoring and management, and we also look forward to expanding the capacity in the country to create a more robust and more national, subnational kind of a social listening ecosystem. Back to Shereen.
9 minutes.
Thank you so much, June. I think it's so important to hear from and actively listen to and learn from the voices and practical experiences at the country level. So really, thank you so much. With that, this concludes this first session here on regional and country case studies from WPRO in the Philippines. Again, June and I hope that the experiences we have shared today can be valuable and useful to others in their work. Thank you very much. Back over to you, Tina.
Thank you, Jun and Shereen. I think it's really great, the overview that you presented, especially the the thoughts that we build on what we have and try to do integrated information analysis for action. So I would encourage everyone to type in your questions in the Q&A section of the Zoom. And in the meantime, I'd like to invite Supriya Bezbaruah. She's a technical officer for risk communication for emergencies at the WPRO Southeast Asian Regional Office, to perhaps share your screen and join us. Perfect, we can see it perfectly. Welcome, Supriya.
Thank you very much, Tina. Thank you. It's a great pleasure to be here again. I'm Supriya Bezbaruah. I'm the Risk Communication Officer in WHO Southeast Asia region. And I'm very happy to share what we've done in the past 1 year. And we've certainly learned a lot.
Excuse me, Supriya, would you mind? Yes, we can hear you very well. Would you mind switching your view into presenter view so that we can see a big screen of your presentation?
Oh, yes. Great.
Perfect. Thank you.
Thank you. So in SEARO, our story for social listening actually started in 2019 when we included it as part of our risk communication strategy at the regional committee meeting that September 2019. But we didn't imagine at that time that only 3 months later we would be going, full swing into implementing it. Initially, we were looking at rumors and misinformation. The reason was that in a number of outbreaks that we had in the region, we saw that rumors and misinformation really shot up. And we found that that was also the case when COVID was first reported in the region in Thailand. It was the first reported case in January 2020 outside China. Well, it wasn't COVID then, it was the new coronavirus. And so we focused initially on rumors because Winston Churchill famously said, a lie gets halfway around the world before truth has a chance to get its pants on. This is what happened during COVID. And I just thought I'd show with you the screen for India. India's great passions are cricket, Bollywood, which is their version of Hollywood, and politics and elections. And the three are eclipsed by the search in Google Trends in the last 1 year by the search for COVID. So there's huge amounts of information there, but it's also a problem of plenty. And as we know, that really affects public health if people can't get their information on time. And it's digital media driving the infodemic. There's some very interesting statistics that I found, which said that 1.3 million users joined social media in 2020, which apparently comes to 15 every second. A lot of people say that in the SEARO region, which is mainly developing countries and internet penetration is low, how significant would digital media be? But if you look at how it's increased in the last few years, from almost non-existent a few years ago, right now in India, for example, it's one of the countries where it's really grown. It's more than 50% internet penetration. And in fact, rural areas are also very, very high. So that gives you an idea of what happens in the future. And also people use social media in the context of their lives. So they find something on social media, they share it word of mouth, it's media, it's all interconnected. So it does make a big difference. So we started in 2 types of digital monitoring. First is the rumor and misinformation surveillance and response system in February 2020 in response to the rumors we were getting for the new coronavirus. And a few months later, we started looking at the public interest concerns and questions related to COVID-19. Why rumors? Because it can even kill. These are real examples of the poultry industry plummeting. It lost 13 billion rupees because of rumors that the coronavirus is spread by eating chicken. Chicken is very, very popular here. Then rumors of testing also led to a drop in testing, because there were, rumors that it was actually a scam and health workers were usually getting people into the health centers because claiming they were testing, but actually just profiting from them. Then there's stigma and discrimination, when it was said that the virus spread through meat. Vegetarians started attacking meat traders. So huge cost of misinformation. We started, therefore, with working with an AI tool called Meltwater, scanning conversations, and there were 58 million conversations scanned from 15 February 2020 to 15 February 2021 in 11 languages for 10 countries with keywords around COVID-19. But rumors always are nuanced, and so you need that human insight at the end of the day, because rumors could be the truth, it's just not verified right now. So how do you make that judgment? It's a subjective judgment, and therefore it's through after further filtering this huge numbers of conversations, it goes through human analysis. We also have a partnership with fact checkers who share with us various WhatsApp rumors, because our surveillance is through open digital media. And over 3,000 rumors have been logged and classified in our rumor repository and responded to in various ways if they needed responding, for which I'll come to later. We have an algorithm. This is what we've found over time. We've partnered with Media Measurement, and I believe they're here today. So the black line are the cases in SEARO over time, right up to the latest, where you can see the steep rise. You can see the rumors here, they were not very high to start with. Then as India and Indonesia cases started taking off, the cases here increased as well, increased again, and then there was a slight lull. And then early 2021, late December 2020, it increased again, and even though cases were low, and that is most probably because of vaccines, the introduction of vaccines. And since then, with vaccines and also with the latest rise in cases, we've had very high number of rumors continuing. So out of all the rumors, 24% of rumors concerned vaccines. 19% was of various other categories, including testing, stigma, and others. We do measure, monitor those that dismiss rumors as well as those that are rumors, but only 9% dismissed a rumor. Most of them amplified the rumor. And what's really concerning is, although 64% of rumors were not trending, well, a significant chunk was trending. So this shows the rumors in different buckets by engagement, which is the yellow bar, and volume, which is the green bar. And as you can see, vaccines are very high in terms of engagement, but also by volume, they form a quarter of all rumors that we detected. And the other big chunk is cures, which is, well, 18% of volume and 17% of engagement. This is what we found by country. As you can see, vaccines have very high number of rumors and cures. Some also do prevention behavior. And the countries, the red one here is India. The blue one is Indonesia, this light blue one. And the green one is Maldives. And those are the ones mainly driving rumors in the Southeast Asia region. So how do we analyze it? We look at them for engagement, for reach, for volume, whether it's trending or not, who is spreading them, is it a famous influencer, but also for the level of harm. And then if it's not serious, the rumor, then we just monitor it. If it's serious and has a global impact, I usually share it with my colleagues in headquarters. If it's country specific, we inform countries. And if it's a regional impact, then we look at the region. We then respond through various ways. Now, the second part is looking at public perceptions and concerns, similar process, 11 languages in 10 countries. And we look at volumes, topics, sentiment, also highly engaged questions. And then based on the perceptions, we then respond in various ways. These are some of the communication measures we respond to. We developed a campaign against stigma and discrimination based on what we found in social media, on our perceptions monitoring. Some key lessons that partnerships are essential. You can't do it alone. And it's online and offline is critical to get the whole picture. We also need a better understanding of rumors in encrypted and perceptions through encrypted social media like WhatsApp, which is driving a lot of digital information. We also need to do better about how to manage uncertainty, because uncertainty is what drives rumors. Finally, infodemic management is about people, so trust is the key. Thank you.
Thank you very much, Supriya, and also for staying up late to be with us today. This was really interesting sharing of your experience. What strikes me is the diversity of rumors that you described that circulate, and I think that's also reflecting the fact that infodemic management really supports and can support the epidemic management much better. By really looking at building the trust and promoting verified information and informing communities. So thank you. I see more questions are coming in. Please do continue writing questions in the Zoom Q&A. And I would, with this, like to invite Elodie Ho and Ibrahima Kaba from the WPRO Regional Office for Africa to please share your screen, your presentation, and your experience with social listening and a case study from Guinea. Welcome.
Thank you very much, Tina, and thank you, everyone. Thank you for the opportunity for us to present. So this presentation will be in French for the French-speaking speakers here today. So bonjour à tous, bonjour et bonsoir. Donc aujourd'hui, en fait, on voulait vous parler d'une expérience qui n'est pas liée au Covid, mais plutôt liée à Ebola. Donc on va prendre en fait le cas de la Guinée et ce qui se passe en termes de veille des réseaux sociaux. Donc en fait, voilà, c'est un peu la structure de notre présentation aujourd'hui. Donc je vais d'abord vous parler en fait d'une alliance qui s'appelle AIRA et surtout ce qu'on fait dans la région africaine pour soutenir en fait le développement de la gestion des infodémies. Ensuite, je vais passer le micro à mon collègue Ibrahima Kaba, qui est vraiment sur les premières lignes de la réponse Ebola et surtout pour la gestion de l'infodémie. Donc peut-être quelques mots sur AIRA, si vous n'avez pas entendu parler de cette alliance. En fait, AIRA est le travail que nous faisons en gestion de l'infodémie en Afrique. Donc AIRA, ça veut dire African Infodemic Response Alliance. Et ça a été créé en fait en décembre 2020. Donc on a à peu près 5 mois d'existence. C'est une alliance dont le but est de limiter la propagation de la mésinformation et de la désinformation en santé publique et aussi de promouvoir la circulation d'informations vérifiées et de confiance sur les réseaux sociaux, les médias et aussi dans les communautés. Donc parce qu'on sait que la lutte contre l'infodémie ne peut pas se faire seule, nous avons constitué un réseau de 14 membres qui ont chacun une expertise à apporter en infodémie, qu'il s'agisse en fait de la veille des réseaux sociaux, de la coordination, de la recherche, de la mobilisation au niveau communautaire, ou en fait n'importe quelle expertise qui contribue aux 5 piliers stratégiques d'AIRA. Donc vous avez des exemples en fait de nos partenaires clés et des membres. Donc vous avez bien sûr UNICEF, Gavi, vous avez aussi le réseau de la Croix-Rouge et de la Fédération, UNESCO, et aussi on travaille beaucoup avec les organisations de fact-checking en Afrique. Et quand je parlais en fait des piliers stratégiques d'AIRA, donc vous le voyez ici, hein, c'est la coordination, la recherche, le plaidoyer, Viral Facts. Viral Fact, en fait, est un service de production de contenu virtuel pour contrecarrer les rumeurs. Et enfin, le service de soutien technique au pays. Donc, en fait, c'est dans le cadre de cette activité de soutien technique au pays qu'on voulait vous présenter le cas de la réponse Ebola et de la veille des réseaux sociaux pour la réponse Ebola en Guinée. Aussi, à savoir peut-être qu'effectivement, la Guinée, on soutient de manière un peu plus rapprochée. On a effectivement 8 pays prioritaires, donc ils sont en rouge sur la carte, mais on fournit effectivement du soutien technique à toute la région AFRO de l'OMS, donc à peu près 40 pays. Donc sur ce, je vais passer le micro à mon collègue Ibrahima. Ibrahima, à toi.
Bonjour Elodie, merci beaucoup. Bonjour à tous. En parlant maintenant de la maladie épidémique, la résurgence de la maladie. Next slide, please. Ressurgit en février dernier, suite au décès d'une infirmière, l'épidémie de la maladie à virus Ebola a été déclarée à Zélékoré par les autorités guinéennes le 14 février 2021. Depuis cette date, 23 cas ont été notifiés, 16 confirmés, 7 probables, 12 décès, dont 5 confirmés, 7 probables, et 10 sont sortis guéris du centre de traitement épidémiologique. À ce jour, 8 678 personnes sont vaccinées, dont 2 537 travailleurs de première ligne. Le dernier cas confirmé a été enregistré le 2 avril dernier. Next slide. Parlant de l'écoute sociale en Guinée, selon le site web Data Reportal, la pénétration de l'Internet en Guinée est de 21,8% en janvier 2021 et 15% de la population utilise les médias sociaux. Du 1er janvier au 29 avril 2021, seulement 3% de la conversation sur Twitter a été menée par les professionnels de santé. 81% des utilisateurs de Twitter qui ont alimenté la conversation étaient des hommes. 65% d'entre eux ont une vingtaine d'années. Donc, c'est un peu la couche juvénile. Et ces utilisateurs sont influencés par la RFI, Lamine Guirassi, qui est un influenceur du pays, qui possède une chaîne de télé et de radio à travers le pays, et Jeune Afrique. Donc, toujours parlant de l'écoute sociale, une analyse hebdomadaire est faite de l'écoute sociale d'Ebola et produits partagés pour trianguler les informations et éclairer les décisions. Next slide. Donc, voilà un peu le système de gestion des feedbacks que nous avons mis en place au niveau préfectoral avec nos partenaires, l'OMS, l'UNICEF et la Croix-Rouge. La Croix-Rouge, ils ont des mobilisateurs sur le terrain qui collectent les informations. Et ces mobilisateurs remontent au niveau des lead journal, comme vous voyez sur le schéma. Les lead journaux là font une sorte de synthèse qui vont présenter au niveau de la plateforme One Health qu'on a mis en place dans chaque sous-préfecture. Ça, c'est au niveau sous-préfectoral. La plateforme One Health, il y a la santé qui est représentée, l'environnement et un peu tous les aspects de la vie de la sous-préfecture qui sont représentés là. Donc, une sorte de synthèse va être faite là-bas et prévalidée par les autorités locales. Maintenant, ils vont remonter au niveau maintenant du CREC. Le CREC, c'est la commission communication de risque et engagement communautaire. Il y a un groupe de travail qu'on a créé, on a mis en place là-bas qui s'appelle groupe de travail feedback. Et à ce niveau, il y a un premier travail technique qui va être fait pour essayer de classifier les feedbacks, les rumeurs qui ont été remontées et tous les feedbacks communautaires qui ont été remontés. Et on implique à ce niveau les socio-anthropologues parce qu'eux, ils sont près de la communauté, ils sont tout le temps sur le terrain, ils savent ce que la communauté pense et tout ce qui se dit raconte comme rumeur au niveau de la communauté. Donc, les vieilles réseaux sociaux aussi, à travers nos outils que nous avons mis en place, on essaie de recueillir aussi les informations à ce niveau. Au niveau des médias locaux, il y a des émissions interactives qui sont organisées, des tables rondes, et ainsi de suite. On a établi des fiches dans lesquelles ils recueillent toutes les informations qui sortent de l'ordinaire, c'est-à-dire des rumeurs qui peuvent affecter la riposte. eux, ils recueillent, ils envoient au niveau maintenant de la gestion des feedbacks. Quand on fait un travail technique, on monte maintenant au niveau préfectoral. Le niveau préfectoral, c'est là où se trouve la coordination de la riposte. Tous les partenaires y sont présents. Maintenant, en fonction maintenant de la catégorisation des rumeurs, les réponses vont être préparées pour revenir maintenant au niveau de la communauté. Si, par exemple, parfois la communauté peut avoir besoin de certaines choses, parfois il y a
We seem to have lost Ibrahima.
À leur tour, on relaie les informations au niveau des...
Okay.
Allô? Allô?
Ça va bien. Continuez, s'il vous plaît.
Ah, ça marche. Donc, eux, ils relaient maintenant au niveau de la communauté et les religieux, surtout, sont beaucoup plus impliqués en matière du retour d'informations du terrain. Donc, on se sert des leaders communautaires comme leaders pour pouvoir passer les messages à la communauté pour apaiser un peu les rumeurs, pour faciliter le travail des vaccinateurs et de nos équipes sur le terrain. Donc, eux, à travers même, il y a une qui avait témoigné, slide suivant, qui avait témoigné pour dire que c'est à travers les prêches que l'imam, cet imam que vous voyez sur le stade, faisait, qui lui a poussé à aller se faire vacciner. Sinon, elle était contact d'un contact, mais elle refusait de faire vacciner parce qu'on les a fait croire que le vaccin, c'est pour inculquer la maladie. Donc, à travers le feedback que l'imam a fait dans la mosquée, donc il a été vacciné. Slide suivant. Maintenant, au niveau des challenges, des défis, il y a une surcharge de travail des agents chargés de collecter les rumeurs sur le terrain. Ça, c'est un défi qu'on doit relever parce qu'ils sont partagés dans beaucoup de tâches. Il y a un manque de coordination des systèmes d'écoute sociale au niveau préfectoral. Si ça réussit, on va l'élargir. Il y a aussi moins de temps consacré à la gestion des feedbacks communautaires. Donc, la plupart des représentants qui font ça, ils font beaucoup d'autres boulot à la fin. Donc, les bonnes pratiques qu'on a tirées, il y a eu l'implication des socio-anthropologues dans la collecte des informations. Et il y a eu la mobilisation et l'adhésion des autorités locales au système de gestion de retour d'informations. Il y a eu un partenariat avec d'autres agences, UNICEF, Croix-Rouge, pour le partage des outils de collecte. Donc, next step, nous avons assuré maintenant une meilleure coordination entre les différents acteurs sur le terrain et travailler sur le système de gestion des feedbacks pour améliorer la coordination et impliquer davantage les autorités. Je vous remercie.
Thank you very much. Another great presentation, bringing us more into the context of the challenges listening in the offline communities in a very different setting, but a challenge and the aim of the work is the same. What struck me is really the importance of engaging the community leaders, especially the religious leaders in this context, and also that you're making a big effort in engaging local authorities and other partners really down at the local level to try to understand both the analysis of the feedback and then also follow through. Thank you very much for your presentation. Indeed. So I would like to move us to the next, and I apologize to everyone. Merci. I apologize for running us on schedule, but I have the commitment to make sure that we hear from all of the speakers first. In the meantime, please do submit question and answers in Zoom. And we already see the slides from Dalia Samhouri from the WPRO Eastern Mediterranean Regional Office, who will share the experience of the colleagues, in the WPRO colleagues there. Please, welcome.
Thank you so much. Can you hear me?
Loud and clear, everything's good.
Very good, thank you so much. And thank you so much for this opportunity to present the experience from the regional office for the Eastern Mediterranean, but also to highlight that this is an initiative that has been running on for quite some time. And it really came in collaboration with UNICEF, with IFRC, and most importantly with the interagency working group that we have put at the beginning of the pandemic and currently run by the three organizations. So if you can move to the next slide, just I mean, a little bit of a background on why we have started with this initiative to strengthen social listening and community feedback. I think as most of you or all of you know that there has been, or at the moment, there are a lot of mechanisms going on in countries with their social listening or community feedback. The understanding of those mechanisms is not really clear to everybody who is working in this area of work. The region is not different from the whole world in terms of the challenges related to infodemic, but also the most important thing is that we mostly lack the real-time information in order to inform the response to the pandemic or other health emergencies. And therefore, WHO, in collaboration with the two different organizations, UNICEF and IFRC, but again, with the collaboration of the Interagency Working Group, we decided that we need to look into this issue from evidence-based, but at the same time, to make sure, practically speaking, we understand what's going on on the ground and how we can put together a mechanism that would serve the whole region. So we started with this initiative back in February, basically 2 or 3 months back. And if you move to the next slide, one of the most important things that we discovered during this this initiative is that the understanding related to social listening and community feedback is not really consistent. Some organizations, they're having social listening mechanisms or tools on the ground, others they're having community feedback mechanisms on the ground. With the difference in the definition of both mechanisms, it's really very difficult to draw a line between both of them. But the most important thing is that both of them, they can provide community insights. And the most important thing, and this is what we are aiming for, is really to have a systematic approach in countries where these community insights can be captured, reviewed, analyzed, and inform decisions whether to manage infodemic or to add this in a bigger picture, the risk communication, but of course as an integral part of the response to COVID or other health emergencies in the future. Thanks for moving to the next slide. So this initiative included 6 steps. So the first one is really to make sure that we have a unified understanding when it comes to social listening and community feedback, and that came very clear after we had the first meeting with the different organizations to clarify the definitions and what is the main purpose behind social listening and community feedback. We recruited a main consultant who has been leading this work, but also the colleague has been supported by a number of colleagues from WHO and from UNICEF and from IFRC in order to be able to run the process. And of course, a lot of support was given by the country offices to facilitate the whole process. We conducted the assessment. After that, we convened capacity building workshops, basically focusing on the main players in this area of work to make sure that we are all on the same page. And we are at the moment in the process of developing an operational model and a roadmap that will be coming out after conducting an expert consultation that will be looking into the recommendations that I will take you through at the end of this presentation. If you move to the next slide, thank you. So basically the assessment that we have conducted, it included 3 steps. The first one is this review, and for this we basically looked into different guiding documents and tools, the strategic framework that EMRO has put in place, but also different examples for the social listening and community feedback that we have captured, but also we have been reading about. We also conducted an online survey, and this was a designed survey to better understand the ongoing efforts, successes and challenges. And at the same time, we also conducted key informant interviews with selected experts at the country and regional level. And the most important thing that these interviews basically help us to understand what were the enabling factors and barriers for systematic listening, and which was our ultimate goal to reach after that. If you move to the next slide, for the online survey, basically we had responses of 41 coming from 19 countries, whether country offices or ministry officials or different organizations. And those responses basically were coming from different representatives at the country and regional level. We have used the Kobo toolbox, and that survey was opened during the period of 24 February until 18 of March. Next slide, please. The key informant interviews were conducted, and we managed to conduct 46 interviews. These included 77 persons, and these were coming from 17 countries, from different organizations, as you can see on the right side of this slide, but also the regional office for EMRO, AFRO, and Asia Pacific. At the same time, we had also interviews with colleagues at HQ just to make sure that we are harmonized and aligned when it comes to the overall process and how we're going to move forward. If you move to the next slide, I will take you quickly on the main findings of these. I'm sorry for that. I'll take you through the main. Can you hear me? Yeah. Main findings of this assessment. So the first slide is basically on the main challenges. So reaching to the most vulnerable population has been identified as the main challenge, and therefore there has been a call to use the offline engagement, because the online one would be sometimes mostly difficult due to the lack of connection to social media. A lack of coordination between the different players on the ground, and therefore the roles and responsibilities were not clear. How to make sure that we're focusing on the broader picture and not only focusing in a haphazard way or only on limited activities. Data analysis was major area of a challenge. In a way, this needed a lot of improvement, and the work with the government has been additionally challenged in a way that the mistrust that has been observed in some of the countries also had added to these many challenges. If you move to the next slide on the main barriers, insufficient capacity, whether technical or human resources, political sensitivity in a way that some of the countries we observed that governments were not really promoting the open communication, and therefore making sure that we have really a system in place would be pretty much challenging. Again, as I said, with the lack of coordination, there has been a lot of duplicating efforts. There has been a lot of competition, lack of sharing of community insights between the different organizations that are dealing with this area of work. Of course, there is no systematic approach, and the barrier related to language also has been coming out as a major barrier, particularly that most of the organizations that are serving on the ground, they're basically using the English language when it comes to the social listening and community feedback, even with the material that are being produced. Of course, there are some efforts to translate those material or these efforts into the local language, but this is still considered as a barrier that needs some work. If you move to the next slide with the main successes, in few countries, we have observed a good relationship between NGOs or local NGOs and the government, and this really facilitated the work, making sure that we are working with the community directly through local volunteers or community leaders. The availability of data really highlighted some of the important challenges that communities are going through and really informed decisions. And therefore, this has been observed in very few countries where the information was available. The sharing of insights has also been identified as a main success, and using the different platforms, whether they're at the regional level or at the country level, to share those insights and to act accordingly. If you move to the next slide on the main enablers, and again, as main findings from this assessment, the experience prior to COVID has been a main enabler, and particularly if we talk about the polio and how community engagement has been a major area of work if you want to facilitate reaching goals related to the polio program, and therefore building on these efforts could be used as could be observed or could be perceived as an enabler to the systematic listening. Sufficient human resources have been seen in very few countries, and we consider these sufficient human resources as a main enabler to facilitate this area of work. Of course, the availability of tools and guidance, and at the moment we have to build on the momentum related to vaccine. We have a lot of challenges, but also we have a lot of successes that we can build on, and therefore this can be considered as the main, if you want, turning point where we can really invest more when it comes to social listening and community feedback. Next slide, please.
9 minutes.
Thank you. When it comes to the capacity building, we so far managed to conduct a series of workshops that included many players on the ground. And at the moment, we are finalizing the package to have a ready-to-go package that can be used by the different countries, by the different organizations, in order to make sure that we have a systematic way of building the capacity of the human resources. And if you move to the next slide, which is the last one, these are the key recommendations that came out from this assessment. One is that we want to strengthen and clarify the role of the different organizations, and this will help in increasing coordination to build capacity of human resources in so many different ways, as you can see in this slide. And not only to invest in human resources, but also technically speaking, we need to work a lot in building the capacity in the different areas, and mainly data analysis and the use of data and the triangulation of the data that will be coming from the social listening and community feedback with the other elements, with their EP, with their social measures, in order to be able to capture the full picture. It's very important that we always localize the support to communities, and of course, to make sure that we have standard operating procedures for the systematic approach. And if you allow me to conclude my presentation by commending our colleagues in HQ for having the EARS platform, which we considered as a very important platform that would facilitate a systematic approach of social listening and community feedback. With the support of our colleagues from HQ, we're managing to expand this platform in 5 countries. And really the idea is to expand it in the other countries in the region. But the most important thing is that we're using 5 countries where there is no system at the moment. And in the future, we want to make sure that there is a very standard way of doing the social listening and the community feedback, and making sure that the different systems run by the different organizations are really aligned. And most importantly, they're saving the collection and analysis of community insights. And this will help in informing decisions and moving forward. And thank you so much for listening to me.
Dalia, thank you very much for this summary. I think really the learnings and the recommendations that you presented, they're really rolling over into a social listening system. And not just in building capacities for the response, but then this is something that can really look at strengthening the systems, both with the health authorities but also partners in how to institutionalize. So I really appreciate the recommendations that you summarized. I'm quite sure there will be lots of discussion on this. Thank you very much. And I would like to ask now the colleague from WPRO European Regional Office, Simon van Beurden, Risk Communication and Community Engagement Officer in the Health Emergency Program, to also share experience from his team, from his work. Welcome, Simon.
Thanks very much, Tina, and thanks to everyone for being here today and for this great opportunity to learn and exchange, as Tina said, some things that we've been working on in the region. So just as a bit of context, in our region, infodemic management and social listening have long been a part of our efforts on risk communication and community engagement, or RCCE, including in the COVID response, of course, but also going back about a decade of capacity building work in that area, including elements of rumor management, listening, and community feedback. So building on this, from the very first day of the pandemic, WPRO Europe focused on bolstering that work, including formative research, social listening, to really inform strategy and messaging, not only for the COM pillar, which is our team as part of the broader response team here in the regional office, but also for that broader setting and even for the leadership of our regional office. So in the next 10 minutes or a little bit less, hopefully, I'll go over some of the key guiding documents to give a broad overview, show how social listening in our understanding connects to community engagement, to really tackle the root causes of the infodemic. We'll touch on a couple of concrete examples of our work with social listening efforts and their early impact. We'll give you a quick overview of a focused project we have on infodemic management, and finally touch on a few challenges and opportunities for the area of social listening. And I'm hoping to take you by the hand with an analogy of music, because I think it can be illustrative for some of the points. So moving along, I'll touch just very briefly on some of the context that informs our work. The general program of work that most of you will be familiar with has a line on protecting 1 billion people from health emergencies. And that's really the biggest picture, I would say, that we're trying to feed into with our work. We also have a regional counterpart to that, which again includes a measure for the emergencies and makes special mention of rumor management, of the infodemic as a challenge within COVID-19, and importantly focuses really on the root causes of that. So one thing that's mentioned in this document is the disconnect that exists between legitimate expectations from people and the concrete experience of a deteriorating environment in health emergencies. So, this connects to our work in a number of ways that we'll see in a moment. But I think this focus on what's the root cause of the infodemic that we're trying to really tackle is really important to remember. As mentioned, we have about a decade of experience building capacity on programmatic RCCE with a couple of key training packages and initiatives mentioned here. And then as part of the COVID-19 response, we have our pillar strategy, and a part of that is a specific project for infodemic management. Moving along, just touching quickly, and this connects to some of the examples that other colleagues from the regions have also given. You can conceptualize social listening as falling on a spectrum of engagement. You can take social listening as the first step, but also if you're looking at the spectrum, you can see it as a second step where you're not just messaging to your communities, you're actively listening to them. But then also that listening and engagement needs to continue as you build trusting relationships that are progressing along this spectrum to more empowerment. And that's really something that we're trying to connect in our team in the region. To not see it as an isolated intervention, but really we think the true value of social listening is as a part of those feedback mechanisms. So not just collecting data, but making sure that we have some sort of accountability over these efforts to the communities that we serve. Just a number of examples. In our musical analogy, this would be some of the instruments that we try to fine tune and have been working on over the course of the pandemic. You'll probably be familiar with most of these, but some examples include CrowdTangle as a tool that we're using to listen for media, as well as for performance of our social media accounts across the region and country offices in multiple languages, and working together with our country offices and partners. We have a number of other tools that we pull data from. The EIOS is one corporate tool that we look at. EARS is a platform that has our interest. And there's some countries that are involved in that, and we're hoping to build on that further. This is an example of some listening that we did in partnership with Hungary, looking particularly at public health and social measures, how the conversations were moving on those. And the PHSM angle is interesting for another reason, as it's the focus of a sort of an inter-team collaboration where our region puts together different dashboards with epi curves, for example, and with key moments in public health and social measure, restrictions being applied or lifted. With that work, we try to see correlations between, excuse me, at the epidemic curve and sort of lifting or increasing restrictions. But now we're also looking at trying to add behavioral and social and listening data to that, so that you can start to see the logic correlations and the causal connections between the announcement of a restriction, the responses to that in online and offline conversations in terms of support or resistance perhaps, and the connection to the epi curve. So that's something we're very excited about. Another tool that we have in place for listening and collecting survey data is the chatbot called Health Buddy Plus. And that is, I just wanted to pull this example to show that there can be some interesting side effects when you're practicing social listening and you're really connecting with your communities. You can see that that is much appreciated, and there's a strong hunger and a need for evidence-based, reliable information on all aspects of the pandemic. Finally, we have a very robust social listening, or rather research tool in place called Behavioral Insights surveys. And yeah, I mean, this is really to show that we have a scala of tools, and we're using the right tool for the right purpose. One interesting example also, or impact of this work with the Behavioral Insights, that Romania has announced that they will be establishing a new unit within the ministry to focus on this work. So that's very encouraging. I'm going to skip a little bit over the coming slides because I see I'm at 7 minutes. But just to mention that, you know, we're not alone in this. As all the other regions also mentioned, partnership is very important, not just with sister agencies, but also with groups of influencers, including faith-based organizations, youth networks, and healthcare workers. It's just a number of the influencers and amplifiers that we're trying to engage with. This is a quick slide on the focused project that we mentioned, that thanks to strong collaboration with colleagues in Geneva and Solidarity funding, we're able to set up. And I think a number of the things that other regions also mentioned will also be focusing on here is, you know, really supporting countries to increase their capacity in this area, make sure we have the science, that we have the data as applicable to the region, make sure we involve the right stakeholders, and yeah, take it from there. A quick look at some of the opportunities and challenges that we can see in the area of social listening. So as we saw with the tools as well, social listening, the increased attention that it's getting, it's really showing us that there's a great opportunity there to have another source of data, or multiple sources of data, with varying sort of degrees of flexibility, robustness, and thus also varying needs for triangulation. So, you know, to quote Mike Ryan, if you need to be right before you make a move, you will never win in an emergency or in a pandemic. And I think that social listening there, we see that it really has a lot to offer. It also has a lot to offer in terms of pairing our organization's strengths with those of tech companies, academia's expertise, sister agencies to an extent. So, you know, lots of exciting things, I think, to look at. There are some challenges that we're trying to consider in our region. Digital divide and inequity, even though has 9 minutes for, thank you for that, has a reputation for being quite strong in terms of internet and tech penetration. We do have to remember to leave no one behind in all of our efforts, including this. Same goes for applying our usual standards of rigor. So that's something else to keep a look at, and make sure that we keep going to the root causes. I'm going to skip over this one just to mention that we've got a number of things in the pipeline that we can be excited about and look forward to. And I just want to end on this slide again as a reminder of what we're really trying to do, and what we should always remember, that, you know, it's a human science, and unless we understand why people are drawn to these sorts of information, we'll always be playing whack-a-mole. And the second quote illustrating that is, it's not about the individual pieces, but really it's about the relationships that underlie and drive this. So with that, I think I'll conclude and hand the floor back to the moderator. Thank you.
Thank you, Simon. Another very interesting presentation. I'm sort of just ticking the box of things that that I've been thinking about also over the last years and a year, and I really appreciate that you know, you emphasize that really, you know, that we have an accountability to communities to really act on what we learn from them, and really, you know, put to action the feedback that we receive. So thank you, Simon, for this. We actually have 12 minutes until for the question and answer session, and I'm going to be bold, and I'd like to ask one short question of each of the speakers. So I would like to ask really just for a 1 minute response from colleagues. And first, because I know it's late and I see that both Jun and Shereen are still online with us, I'd like to go first to you. And this question is about the fact that it's been mentioned several times that social listening definitely has, it's challenged by the languages, the diversity of languages. And, given the fact that you're working with many languages in the Western Pacific, how does that influence your approach? What would be your, 60-second reflection on this?
I can jump in real quick and then I can pass the mic to Jun. Well, this also relates to a question we saw in the chat box about working with partners. So right now, we are currently working with a design third-party tech company who helps with designing our communications materials. And one of those things that they can do is support with translations, which is absolutely incredible because yes, in fact, there are many languages across the Western Pacific region. So in this case, this is an example of how we're able to leverage partnerships to support in this. Jun, did you want to add anything? Over to you.
Yes, I think the question can also be scaled down at the country level because in the Philippines, we have quite a number of languages as well. And here, it's important to do regional level listening. And it's good that at the DOH level, we have a network of health education promotion officers who can practically mirror what is being done at the national level and provide insights at what is happening at the regional level, wherein languages would be specific in their particular region. So what we foresee as part of capacity building is to strengthen these regional networks as well, such that we have a working ecosystem for social listening, not just at the national level, but also at the subnational networks.
Very good, thank you very much. We're seeing the outlines of an ecosystem being described. Supriya, you have been working in a variety of roles for a long time, and I saw some questions in the Q&A that were talking about and asking about what are aspects of literacy that may come into play or that intersect when you're trying to think about infodemic and misinformation and risk communication. What would be, in your view, what would be your reflection on this? How do we, how do they interplay, and and how do we address those?
Thanks, Tina.
I think you. Okay, good. We can hear you.
You can hear me? All right. Yes. I was on mute. So, so by literacy, you mean the level of literacy or education in people, or are you talking about literacy as in awareness about rumors and all of that? Because the two are intertwined as well. Thailand, for example, did some very interesting studies, and they did find that people with high levels of literacy were also more aware of the rumors. And Dr. Firoj led that study as well. So there is clearly, a correlation, perhaps maybe too strong, between the level of literacy in a population and awareness about rumors. But it goes much more than that. It also goes into to cultural beliefs at the local level. It also depends on the situation and the level of uncertainty, fear that's going around. All of that influences how much and to what extent people believe rumors and misinformation. And to the extent that even if they would normally be more rational about it, the context in which they are makes a difference in how they view things, and maybe have a bit of doubt about it. But Thailand's doing some really interesting work on that, on levels of literacy for fake news in the public, and actually a large number of them can recognize fake news, at least 50%, although there's a big chunk that does not. I don't exactly recall the figures, but there's a substantial number that do understand fake news. There's also there's also a large number of people that do share automatically news that, or WhatsApp or whatever they get, without verifying, and that's a level for concern. Does that answer your question? Was that what you were asking? Thank you.
No, it's good. You actually touched on a variety. I think we could have a whole session on literacies and different kinds of literacies, but I think this is a good segue. So thank you also, Supriya, for being with us so late in the evening as well. And I was preparing also a question for Elodie and in Ibrahima. So actually, Elodie, there's questions in the Q&A related to IRA, and I would ask if you could please just directly respond to the questions there. And I would invite actually all of the speakers throughout the events today to please look into the Q&A, and if you have any direct answers, please do respond there. But I have a question for Ibrahima, and I apologize because I do not speak French enough to be able to ask this in French. I was thinking along the lines.
Allez-y, y a pas de problème. Allez-y.
No, super. Thank you. How have the lessons that you've learned through social listening in the communities about Ebola, how did they feed into the social listening on COVID-19? Were there things that you kickstarted immediately for COVID-19?
Merci beaucoup. Mais moi, je travaille sur Ebola. Je ne travaille pas sur le COVID-19. C'est la spécificité. Donc, je ne sais pas, c'est sur Ebola. Bon, moi, je suis dans la zone Ebola. Je travaille sur Ebola.
Maybe I can complement Ibrahima's answer. So, because we have been supporting Guinea, but also other countries on both Ebola and COVID. So basically, what we're trying to put in place, the systems and mechanisms should be adaptable for any kind of public health crisis. So it is built for Ebola in Guinea, but the system is very similar to what we put in place for COVID in other countries. So the idea behind it is really like to empower the Ministry of Health, but also like all the local actors at the district level as well, so that they can use this system for other pandemics in the future. I hope that answered your question, Tina.
Thank you. Thank you. Yes. Thank you very much also to both of you for joining today. I'd like to move to Dalia, to the colleague from Eastern Mediterranean Regional Office. You know, one aspect from your presentation that came out that was also related to vulnerable populations and offline populations. And I was wondering, you know, how could you better engage with vulnerable populations that cannot be reached very well by social media? And what would, you know, how are you thinking about this, and what do you have in place or are building for that?
Well, I think we do have a number of experiences that we can share. For example, and again, building on existing programs, not something that we have started because of the COVID, but building on what has already been in place. So the first one would be the religious leaders as the line of communication between decision makers and communities, and particularly those that are living in the hard to reach areas. And I guess we have a great example coming from Pakistan and Afghanistan, and particularly to manage the polio program, where the religious leaders have been having a great effort, if you want, or a great part in in making sure that the program is running the way it should be. Of course, there are some hiccups here and there, but the role of religious leaders is pretty much important. We also have examples of community workers, and I'll give you an example from Somalia, where community workers have been also providing great role to reach out to communities and those who are living in the hard to reach areas. But I think the most important thing is that you have the communities, and then you have the different players, whether WHO or the different organizations or even the government. And then you have, for those communities, there are parts where we cannot reach them or the government cannot reach them. But there are some infrastructure in some countries that would facilitate this kind of work. The community workers is one of them. volunteers, a network of volunteers that is pretty much run by IFRC, and this network is also managed by the civil societies on the ground. And the most important thing, you have a bunch of NGOs, local NGOs that are basically serving in a lot of areas, and those are pretty much tremendous amount of organizations. We've been doing a lot of mapping of those NGOs and civil society organizations to understand their scope and to understand the way they work. And the most important aspect for us is really to identify the main organizations where we can have the line of communication with them, and hopefully this will help our efforts to streamline the social listening and community feedback by making sure that those different networks are part of the overall structure for streamlining this kind of work. So again, for this hard to reach area, the offline listening is the most important thing, and we're using the different networks. It really depends on each country, and it depends on the most trustworthy network that can be used for this purpose. Thank you.
Thank you, Dalia. I think that also indicates the types of networks we need to have on standby, so that when there is an emergency, they can be activated and or scaled up. So thank you so much. Simon van Woerden, last question for you. Do you have any tips for translating digital intelligence and other types of data that you presented, you are working with in your team, in your region? Do you have any tips on how to translate those into risk communication, community engagement action? So the being accountable to the communities.
Yeah, great question, Tina. Not an easy one for sure. I mean, I think it comes back to the different tools you have for the different purposes, right? If you're, depending on your situation, you might want something quick and dirty that can just give you an anecdotal understanding of topic areas that you need to be active on. Or if you're trying to convince a very important stakeholder like national health authorities, you might need more robust data. So this is also something that we're applying in our region, is the behavioral insights research. We're rolling that out in close partnership with national health authorities, making sure that we really pay attention to collecting the data in partnership, translating it into recommendations that are actionable, and ensuring that the ownership is with the right stakeholder. So I think that it comes back down to what are you really trying to accomplish. I'm trying to think if there's another concrete example that I could give. I mean, you're listening to your communities. Sorry.
This was quite a good reflection already, and I didn't want to put you on the spot. It is the golden egg question that we're going to be asking all the way through the conference.
No, I mean,
but
this is great.
Thank you.
If I can add one more reflection, Tina. I mean, everything we do,
seconds.
right? It's about serving our. Yeah, sure. I'll keep it short. Everything we do is about serving our communities. So when you're thinking about the kinds of, it also goes into the kinds of listening and the data that you're collecting. Like what questions, what research questions are you asking? And that informs your data collection, and that informs recommendations and then actions that hopefully tackle those challenges. So if you're thinking about the root causes of the infodemic and the rebuilding of trusted relationships, the gap sometimes between expectations and actual health services, I think that's really questions we need to be asking ourselves. And also, too humble, make sure that our analysis and data gets to decision makers. So not just go back to the communities, but also think, is this something that we need to tell our EPI colleagues, or is it something we need to tell clinical people they should be aware of?
Yep. Thank you, Simon. +1 from me, definitely on this. This reminds me also of what our colleague from US CDC, Liz Wilhelm, often says, that in addition to being accountable to the communities to act on what we learn from them, what we also need to do is be committed the second pillar of infodemic management or social listening is the commitment to evaluation and really, only collecting the information that we have and then really taking the responsibility to use it in the most effective ways possible. So thank you, Simon, to you as well. And I would like to ask to thank the first panel for being with us. And we will move over to the next one. So in the meantime, I would invite and remind everyone to please definitely stretch your legs as you're listening to us. Get up off of your chair. But please do come back and add more questions to the next set of panelists. We have 4 talks. And in interest of time, again, I would like to ask each of the speakers to really stick to 10 minutes so that we do have the ability to then discuss with you. And I would encourage you also, please do interact in the Q&A section of Zoom to also answer in writing any of the questions. So I would like to then move to the first speaker in the second set. Isabelle Sahinovic from the Global Vaccine Safety Group at WPRO Geneva will be speaking about how to leverage technologies to inform vaccine safety. I see the presentation already online, and Isabelle, over to you.
Thank you, Tina, and good morning, good afternoon, and good evening, colleagues. So my name is Isabelle Sahinovic, and I work in the pharmacovigilance team at WHO headquarters, and I also manage the Vaccine Safety Net, which is better known as the VSN. Quickly, just to tell you about the VSN, the VSN is a worldwide network of websites verified by WHO that provide reliable information on vaccine safety. The project was initiated in 2003 to counterbalance groups using the internet to question the utility of vaccination and offset websites providing misleading and alarming information on the safety of vaccines. The VSN has 2 main goals. One is to facilitate the access to reliable and science-based information on vaccine safety for internet users, regardless of their geographic locations, cultural background, language, and health literacy. The second one is to collaborate not only within the network, but also as a network with other similar initiatives. One such a collaboration is the Web Analytic project, which allowed the VSN members to have access to Pulsar, a UK-based audience intelligence and social listening platform to monitor the performance of their online content to inform and tailor their vaccine safety information and communication intervention. With no further ado, we will be listening to Claudia Day, VSN Pulsar focal point, who will present a case study on how insights from the platform are used for the benefit of the VSN members. She will use the example of tackling COVID-19 misinformation in Brazil. Over to you.
Good afternoon, everyone. I'm Claudia Day, and I work at Pulsar Platform. Pulsar Platform is an audience intelligence and social listening platform, and we look at segmenting conversations and audiences online. Today, what I'm going to focus on is looking at the conversation around vaccines. We've set up this this query to look at global conversation, but today I'm just going to focus on Brazil specifically. This is to exemplify how we can segment different conversations by market in order to inform comm strategies for different organizations in those different markets. We are just focusing here on the last month, but obviously that can be extended depending on the time period of interest. To be able to understand this conversation, obviously it's key to see what levels of conversation there are. So in Brazil, we can see here that the conversation is fairly consistent, and also that there's a high level of engagement on this conversation within Brazil. In terms of the most engaged with content here. We're looking at the posts by highest impressions. So these are the pieces of content that are sort of resonating and getting in front of as many people as possible. And you've got here some blog content coming through, some Twitter content and some news content as well. So you can see here already some themes coming through in terms of the different vaccines that people are discussing. So we've got AstraZeneca coming through here, we've got China, and we've got Johnson & Johnson. It's also key to understand for those comms strategies, what are the most used hashtags? And this can be looked at by keywords and topics as well, to identify and inform what you should be using within your copy, to get your posts and your content in front of the right people. It's really important to understand where this audience are getting their information from, and you can see that from the links and articles that they're sharing online. So you can see here already immediately that the audience within Brazil are actually very much looking at the international conversation, the global conversation around vaccines. You've got the European Pharmaceutical Review coming through here, the Manila Times, and CNBC. And you can also see that, again, some of these key vaccines are coming through in terms of the articles they're sharing. So we've got Pfizer coming through here quite a lot, and Sinovac. And you would interpret from this that the Sinovac conversation is going to be definitely more negative than that of Pfizer. So it will skew that sentiment. Again, this just further reinforces that sort of international level conversation, and the fact that they are interested in that global conversation, and that really is influencing their decision making. And you can see here that the conversation across all of the different vaccines is fairly high. Especially on that spike on the 13th of April, which we could click through to and see what was going on there on that particular day if we were in the platform. But I think that by and large, you can see here that Moderna is the least talked about, and Johnson & Johnson, Sinovac are getting a high level of conversation. You can start to then drill down into the sentiment of each of these. So as discussed, we anticipated from the content that was being shared that the Pfizer would have a bit of a negative swing, which it does. And then you can start to see, Johnson & Johnson has the biggest negative swing. And then you can see that Sinovac, people are very opinionated either way. There isn't too much neutral conversation. And you can also see here the split between the different vaccines and the conversation as a whole in terms of the volume. And actually there's a big proportion of the conversation around vaccines that is talking about no company at all, which is interesting because people aren't necessarily always talking about the company itself. It's more about the vaccines and their impact. Good afternoon, everyone. I'm Claudia Day, and I work at...
Thank you, Brian. So we would like also to share with the audience another important activity that has lately been initiated by the WHO pharmacovigilance team, and that aim at bringing an AI-enhanced approach to public data and document analysis with a focus on early detection of COVID-19 vaccine safety conversational signals. Carla Berrer, professor at the École Polytechnique Fédérale de Lausanne in Switzerland and CEO of Linkelong, will explain the advanced natural language processing algorithm the platform adopts to understand the context of a given conversation so we can easily classify them to spot emerging trends and information signals related to COVID-19 vaccine safety. Over to you.
I'm Carl Aberer from EPFL and founder of Linkelong, an EPFL startup. In this short presentation, I wanted to introduce some recent developments showing of how to take advantage of artificial intelligence and in particular deep learning for analyzing and interpreting text conversation as we find them, for example, in social media. Traditional tools for analyzing text content like social media listening tools are largely relying on the use of keyword searches as shown in this example query, searching for documents on a given topic such as COVID and vaccine. This approach can be improved by using a first generation of artificial intelligence tools for natural language processing that are able to understand the meaning of individual words. Using those, it is possible to automatically infer which words have a similar meaning, like vaccine is similar to jab, shot, and so on, or that certain hashtags like China virus carry a meaning that is related to COVID. Using these tools, it becomes possible, therefore, to increase the number of documents retrieved for a topic. More recently, a second generation of AI tools have become available. They are based on so-called deep transformer networks, the same technique used in language translation. Those tools have the ability to understand the meaning of sentences, and this has important consequences on what type of analysis we can perform. Let me illustrate this point by means of an example. Assume you're searching for reports on fatal cases occurring after COVID vaccination. Using a traditional topical search for COVID and vaccination, together with the search for the disease of person, will produce two kinds of results. Reports on fatal cases that we are interested in, as illustrated on the left, and other documents mentioning vaccination and the disease of persons for various reasons. Using a keyword-based approach, these two types of documents are indistinguishable. Using deep transformer networks, we can capture the sense of these documents and correctly classify them into genuine reports on fatal cases that we are interested in and other relevant documents. Thus, we can select the relevant topical documents. What is the benefit? We tested this concretely with our Peak platform, where we have implemented the technique described. We find that we currently spot about 300 posts per day on Twitter on the topic on COVID and vaccination that are mentioning also the disease of a person. After applying our sense filtering, we find that less than 10% of them are relevant reports. Therefore, we could reduce the workload of an analyst interested in this data by more than 90%, which is significant. So this brings me to the end. I'm happy to answer any questions in the following Q&A session.
Thank you, Carl. So by leveraging the use of such techniques, WHO hope to share such insight to inform online vaccine safety communication interventions. It is also aimed at providing latest scientific information on COVID-19 vaccine safety by sharing them with the VSN and timely disseminate such information via channels such as the WHO Facebook Messenger Health Bot or on Wikipedia, for example. So that is from our side. Tina, thank you very much.
Thank you, Isabelle, for bringing these two examples forward. As everyone's guessed, this session is on really using approaches in computational data science and how they can, help us cope with this abundance of information and help us inform insight. So it's really also great to see how the VSN is leveraging this to empower and inform all of your members. I'd like to move to the next speaker, Joseph Elliott Bullock. He's a data scientist at the United Nations Secretary General's Innovation Initiative on big data and emerging technologies. And Joseph and his team have been working on very interesting application of computational data, social science, data science for, I would say, offline social listening. Joseph, over to you. Welcome.
Thank you very much. Can you hear me and see my slides? Okay.
Everything okay? Yes.
Wonderful. Thank you. And thank you for the WHO for hosting this event and for inviting us to give a talk. I'm just going to keep my camera off for the presentation because my internet was a bit unstable this morning, but I will risk turning it on for the Q&A afterwards. So I'm going to talk a bit about a project that we've had that's ongoing with WHO, with the Infodemics team, on using radio listening for social listening, public health in Africa. And I'm going to talk a bit about our approach and then briefly mention some of our initial findings as well. So as you just heard, a brief introduction to Global Pulse for those who are not familiar. As was mentioned, we're an innovation initiative of the UN Secretary General. We use research and innovation for sustainable development and humanitarian action. And we do this across a lab network. We have 4 labs, one in New York, one in Kampala, a lab in Jakarta, and a lab in Helsinki. And these labs serve as a space for joint experimentation. We work with UN entities at all levels, headquarters down to country office level, with academia, public and private sectors, and with civil society as well. And actually this project is a cross-lab network effort, starting with a project in Kampala, building on some knowledge from other labs in Jakarta, for example. And this project is also particularly working with colleagues from Helsinki and from New York as well. So jumping right into it, why radio? Radio has a very high number of stations around the world of broadcasting radio. So there's about 44,000 radio stations in the world, according to UNESCO a few years ago. And the coverage is also very high. So around 75% of households in developing nations were estimated to have a radio set which they listen to and use to get some of their news and share opinions as well. So radio is quite different to many of the other channels that are being monitored in social listening. It can give more context than things like Twitter might give, and also is an interesting platform for understanding how opinions are shared, particularly in some more low resource settings. It's also a largely untapped resource for analysis and can be used for uncovering a range of different insights, and can be used in things like early warning systems for monitoring opinions and monitoring systems, as well as for evaluations, for example, for different projects and ongoing situations as well. So we have been working with WHO and other colleagues to develop a radio listening pipeline. The pipeline has multiple stages, and I'll just run you through some of them briefly. So we start with an ingestion module. I hope you can see my mouse. An ingestion module, which is used for listening to the radio stations. We usually listen to online radio stations, but we can also listen to radio stations that are actually being broadcast over the airways that don't have an online presence. We then run this through a speech-to-text model. So we use machine learning models to transcribe the audio from the radio into text that can be analyzed. We also run it through a series of filters to remove things like music and also for various privacy-preserving filters as well that have been developed. And then this goes into analytics module. So here we perform various analytics on the data that we're getting. So referring back to some of the previous talks on some of these NLP techniques, we're also leveraging some quite similar techniques to understand what's being talked about, how things are being talked about, and what are the opinions that are being shared on the radio. And then the analytics goes into a custom visual web tool that we're developing, which will allow decision makers and policymakers to interact with this kind of data and understand and perform some of this analysis themselves so that they can better answer some of the questions that they're asking. We're also looking at how to take this audio and text that we've got, as well as the metadata from the analytics that we're performing, and feed this into existing platforms, such as those at WHO, like the AI-powered early warning system, the EARS platform that has been mentioned, as well as, I'm sure many of you are familiar with EIOS as well, the open source infodemic intelligence system at WHO. So just to quickly run through some of these components in more detail. So the first is this ingestion stage. So we listen to mainly online radio stations. We take audio recordings of about 5-minute segments. We apply these filters, as I mentioned, to remove unnecessary content. And then we store the recordings and the metadata associated with them. So we know, given a 5-minute segment, where this was broadcast from, what city, what country, the date and the time. We then run this through, as I mentioned, a sort of speech to text module. So we use machine learning language models for transcription. We're starting with English and French stations because they have a good coverage in the region. And also there's several existing machine learning models that we can leverage to get us started. However, one of the interesting challenges is that a lot of these existing models are trained primarily on large data sets of audio and text files, which have been derived from mainly the global north setting, largely from the US and the UK speakers, and don't perform so well on a variety of different accents from different ethnic backgrounds. So there was some previous work that came out last year, which is in this chart on the right, that shows the performance on average of some of the leading speech-to-text services when it's been performed on audio recordings of Black men and women versus white men and women. Here, a lower error rate, so a lower bar is a better score. And they found last year already that some of these language models aren't performing so well on a wide diversity of different ethnic backgrounds. And we also have a similar problem in radio. So we have a lot of different countries that we're trying to listen to radio stations from. We're starting in the Africa region, and we hope to develop this more broadly. And so generalizable models that can handle a large range of different accents from all over the world is really important, so that we're making sure we're capturing all opinions equally and including all the voices we want to include. And so we've been working on ways to try and improve these models, to sort of fine tune them and make them better and more robust to different accents. And we've transcribed manually various audio clips so that we can benchmark some of these existing approaches. So for example, we're also in conversations with WPRO, who've developed a model trained on lots of their different WPRO discussions, which therefore encompasses a broad range of accents, as well as some other providers that we're looking at as well. One of the other challenges that we've looked at is the fact that a lot of these models are trained on previous audio recordings and text, which was sort of pre-pandemic, and so they don't have in their vocabulary a lot of the words that are associated with the pandemic that we're really interested in. So the vocabulary of these models is basically the set of words that these models understand, and they're determined by the pieces of text that they were trained on. And so these models may not understand the words COVID, lockdown, or pandemic if they weren't used in the training data set. And so we're also looking at ways to improve these models, to update them to more of the language that we want to be checking in, and the language that's now so familiar to us that was not familiar to us or many of these models several years ago. So the third component is the analysis stage. So we first of all want to detect relevant passages. We initially passed this audio through a series of filters, I mentioned, to remove the music and maybe some adverts and things that we may not be interested in. So we're getting the transcriptions of more interesting parts of the radio conversations. And then we want to select which of the relevant segments of text which are based on the needs of the user or the person doing the analysis. So for example, we can search for text about vaccines, and we may get a range of different opinions being expressed on the radio stations. So these quotations are actually taken from various transcriptions that we've made from different regions already. And you see that we can get a range of different opinions coming out, but how we select these, there's various different methods that we use. So the first is trying to pinpoint key terms that we want to really look at and are interested in. So it's sort of a relatively simple keyword search. But we can cross-correlate this with also some of the metadata we're collecting on, for example, where these discussions are taking place, in what country and what city. So for example, on the left, you can see that we can look at how different vaccine actual manufacturers, so Moderna, Johnson, Pfizer, and the AstraZeneca vaccine are being talked about, and how many mentions they're getting in different cities. This is across South Africa and Nigeria. We can also do things like looking at time series trends, around March in South Africa and Nigeria, sort of around the same time as the EU countries halted their vaccine relative to AstraZeneca because of the blood clot worries, that we also see a strong correlation between the uses of the word clot and AstraZeneca in these regions. So these are kind of things we're using as validation stages at the moment rather than brand new insights, but this gives you an idea of some of the analysis that we're performing and that we can perform. Another more detailed analysis method we're using is topic modeling, which was kind of alluded to in some of the previous talks as well, which is basically a way of clustering discussions around similar topics depending on common linguistic patterns. So again, this is using sort of machine learning based approaches. And this is an example of looking at text that was taken from call-ins. So when people call into radio stations to discuss current issues, it's a really useful source of information. And we're currently working on ways to automatically detect call-ins rather than just scanning over all radio stations. Can we actually find out when a call-in is happening so that we can capture that opinion? And this gives you an example of some of the conversations that are happening in some call-ins in South Africa. You see the first cluster talking about things like vaccine rollout of AstraZeneca vaccine. These are the sort of top 5 words associated with this topic. Topic 3 might be looking at the Johnson & Johnson vaccine in South Africa and how the government is responding to this vaccine rollout. And then the second topic might be a topic around the efficacies of these vaccines in the trials. And then once we know these high-level topics, we can dive into them in more detail and really explore some of these opinions and the ways in which they're being talked about in more detail as a sort of deeper level analysis, which I won't go into in detail here, but this is the kind of pipeline for analysis that we're developing to allow decision makers to really understand these topics in more detail. So the final stage is to build a decision-making tool. So we're developing this web-based dashboard to allow policymakers, decision makers, and infodemic managers to work with this data, to have access to it, and to perform these various analysis stages that we're working on, and to dig deeper and try and answer some of their own questions so that we put the agency into the hands of the experts and the infodemic experts in WHO and elsewhere. And so this is a sort of ongoing project as well, and we're hoping to get feedback from WHO colleagues on the design of this front end and what's useful and what's not in various pilot studies in the coming months. So all of this project has been using our sort of project innovation cycle of Global Pulse. So we started with various pilot projects in our lab in Kampala back in 2016, 2017, where this radio listening project— 9 minutes. Thank you. And then we go through a series of evaluation and user-centered design processes with our various colleagues in WHO to try and work out what is useful to people and what's not so useful, what analysis they're really looking for, what really helps them uncover the insights. So we're really trying to draw on the expertise that different colleagues are bringing from the technical side, as well as expertise from the actual infodemic management side, to make sure we're answering the right kind of questions and providing useful resources and tools to the teams who are trying to answer these questions and make policy decisions based on them. I will stop there, and thank you very much.
Thank you very much, Joseph, for this presentation and basically also practically, getting us through or walking us through the practical steps of what a project like this takes to implement. I feel that actually also the UN Global Pulse pilot projects on radio listening that you had done really are a step to develop new data source and new insights for social listening that will really add to our ability to listen to communities and then also to respond better. And I think this was a good talk for the uninitiated data scientists to also look at the importance of how much work it goes into validation and narrative tracking and things like these. So I look forward to the questions in the chat. Chris, I understand that there's some fresh off the press news, maybe 30 seconds before we go to the next speaker. Great, thank you, Chris. You were on mute? Maybe you should repeat, Chris.
Okay, team, can you hear me now? I'm going to anticipate that you're hearing me. Really delighted to announce the partnership. It's following up on what Joe was sharing here, that we have an announcement web story online, hot off the press, about this collaboration developing the radio speech to text analysis tool to better hear from vulnerable communities as part of our ongoing social listening program for infodemic management. So we're posting that link into the chat. I will also include that for the YouTube video as well. And we encourage everyone to share that, retweet that, amplify that through your social media. Thank you. Over.
Thank you, Chris. Let's move on to the third speaker. Dr. Joe Smicer from the Public Goods Project, working also with UNICEF on social listening strategies. I would invite Joe to please share your presentation and join us. Great. Just to maximize the presentation, and we're good to go.
Great. Can you
Perfect.
hear? Okay, good. Well, it's
yes. Welcome.
Thank you very much for the time today. I'm just going to walk the group here today through a program run by UNICEF in partnership with Yale and the organization that I run, the Public Good Projects, or PGP. We most often just go by PGP. And to start with, don't worry, I am not going to be showing you a dashboard today. I love dashboards, but I know that we all have seen many of them. So I'm going to be explaining the work that goes on in what's called the Vaccination Demand Observatory, but I won't. This won't be a walkthrough of any particular dashboard. The Vaccination Demand Observatory was just launched a week ago. UNICEF made the official announcement a few days ago, so you may have seen it in the press. And so my goal today is to introduce you to this global system and then to answer any questions that the group may have about it. But as you can see, it's a multi-stakeholder initiative, and its goal is to identify, track, and respond to vaccine hesitancy and misinformation in real time. It's a sustainable global network of infodemiologists. I know many of the attendees here today are very interested in infodemiology. I myself was one of the trainers for WHO's Infodemic Manager training, and just finished training a group at Mercy Corps. So I know a lot of organizations all around the world are attempting to train up infodemiologists. And this is a merger of equitable social listening systems with many partners. And the goal is to inform demand generation for vaccines, help manage misinformation in the infodemic, and mitigate vaccine hesitancy and new vaccine introduction. As I said, the partners are UNICEF. For those of you unfamiliar with the work UNICEF has done in immunizations, prior to this pandemic, it was the world's largest purchaser of vaccines. It currently manages immunization programs in over 100 countries. So it is a very nice complement to WHO. UNICEF has offices in each country and a very large number of staff based in the field. They are headquartered in New York City, but 85% of their staff are actually in communities. My organization, PGP, is a public health nonprofit, and we specialize in cross-sector initiatives and large-scale media monitoring programs. And then, of course, Yale's Institute for Global Health is a specialist in research, monitoring, and evaluation, and has a team focused on vaccine demand led by Dr. Saad Omer. There's 3 pillars to the Vaccination Demand Hub. So as I mentioned, there's social listening and analytics, which is really a customizable portfolio of different systems all meant to work together. There is a Vaccine Acceptance Interventions Lab, or VAIL, which is running large-scale RCTs in multiple countries, as well as real-time A/B testing of messages in multiple countries, and then giving that data to country infodemic managers. And there is also the Field Infodemiologist Training Program, which I can go into a bit more detail on in a couple moments. So to start with social listening, unlike other systems that are out there that are excellent, this system is designed from the community up. It's not designed as a global monitoring system. So because UNICEF has such a significant presence in so many countries around the world and has existing systems, community surveys, community health workers that go door to door, a very large established network of community partners. They have a number of social listening systems, both offline and online, that already exist. So the Vaccination Demand Observatory is an attempt to reconcile all of those systems and bring them into one place, and then combine them with more global monitoring systems, so more public media data monitoring systems. That community level data goes to up to a country infodemic manager, And then, like I mentioned, goes to the global system. So this is really all about programmatic support at the community level. It's meant to complement work being done by WHO and others, not to duplicate it. You can see here some examples of the kinds of data that the system is currently being built to bring in. So a whole range of online and offline and traditional data, in addition to UNICEF's own tools like U-Report and some other systems that many of you are probably already familiar with. Just like the other systems we've talked about today, it heavily uses NPL and AI, but again, that's more on the public media data side than the community survey side. And its whole point is to, in real time, in the state of the infodemic, bring in all this data and not present the infodemic manager with yet another dashboard, but with actionable insights that they can actually use in their day-to-day job. And this is really how we're imagining that work. This is the Field Infodemiologist Training Program, which, as I mentioned, is modeled after the Field Epidemiologist Training Program created by CDC and in partnership with many countries all around the world, a highly successful program. So this is what this is planned to be. It's not running yet, but it will be running soon. So it's a year-long program for fellows, so people can apply to this program, and in a series of 3-month modules, we'll learn all aspects of infodemiology, and again, designed much the same way that the FETP program is currently running in over 80 countries around the world. Individuals can apply from their home institution. They may work at UNICEF, but they probably won't. They may work at a Ministry of Health, or they may work at other organizations, and they can be housed within UNICEF's in-country office or within their home institution, whichever one is fine. Like I mentioned, it's built off of the infodemiology training that WHO instituted in 2020. All of us here today, I'm sure, are big fans of that training. And so it's that training built out significantly more. In the headquarters of the Vaccination Demand Observatory, the lab will exist, the creative studio testing messages and creating messages, and then the FITP program. That support will then go to regional UNICEF offices, and then of course down to country offices. I won't go too much into these slides, just to go a little bit more into detail in the lab. The thinking here is the country infodemic manager sees misinformation spiking. They send that alert to the lab. The lab then offers strategic communications guidance and communications templates. Those go to UNICEF country offices, in addition at the same time with their national partners, community partners, and global partners. So this is really meant as a modeling, like a crisis response type system or methodology, but designed for all vaccines and not just COVID-19 vaccines, although of course that's the priority at the moment. Our work to date, numerous webinars, the links are available here. This presentation is available to you all in case you've missed a slide. Don't worry, you'll have this presentation. And then we released the Vaccine Misinformation Management Field Guide in numerous languages: English, French, Spanish, Arabic, Portuguese, and Italian so far. It's been downloaded about 7,000 times since it's been put up, so very high interest in this sort of work. Some of you may have downloaded it yourselves, and so this work will continue in kind of in this fashion. And we are providing in-country support to UNICEF country offices in numerous countries. We started with the 4 that you see here, and we've included a few more since then. And it's been interesting to work with people. All of you work in public health. All of you, thank you. All of you work in public health, so you don't need to be told, but I think those of us working in public health are wearing multiple hats right now. We all have multiple jobs. And so this effort really focuses on how can we make insights as actionable as possible for operations. And yes, there are dashboards. So if you go to this website here and you request access, you can get access to the global dashboard, which is in beta right now, but which provides insights on vaccine-related public media data at the regional level. And I'll go ahead and stop there.
Thank you, Joe, also for presenting this, all of the aspects that you're working on. I think, multi-level organization and support is really important. And I think you really discuss the aspects of building a network to respond to the infodemic for vaccine demand promotion really well. In interest of time, I would like to move also to the next speaker. And we'll see, I think we'll need to decide if we take questions live, Chris, or maybe we end up just encouraging everyone to please ask questions in Zoom, but I would ask also the speakers to respond as much as possible in writing. I am, as a digital health and analytics professional, I'm very much, this session is very close to my heart, but let's see if we can get some questions in. Dominic Shattuck from Johns Hopkins University, I see your slides are already up. I would just ask if you could please maximize. Perfect.
All right.
Welcome, and the floor is yours for 10 minutes.
Thanks so much, Tina. I'm going to share 3 social listening approaches, and we'll try to be light on some jargon today. 2 approaches are technology and media dependent, and a third blends technology with old-fashioned face-to-face contact. This third approach is extremely agile, and all of these approaches are taken from work completed by Johns Hopkins Center for Communication Programs. Although I'm presenting today, there are numerous others whose hard work these slides represent. The first approach is being implemented in Guinea. This team is implementing a social listening approach that falls in line with many of the presentations that we've already seen this morning. To provide a moment of context, Guinea has a relatively conservative culture, and although internet access is growing, it's far from universal. Using AI and qualitative data coding, a review of social media content in French, English, and Arabic was implemented. Our team applied theoretical frameworks to the data and developed several key personas, 2 of which I'll mention shortly. This work is being done to drive interest in social media campaigns focused on a variety of health topics, including COVID vaccination. Within this project, we applied 2 theories that originated at Johns Hopkins CCP. My colleague will drop some citations to both articles in the chat. First, the team used the ideational theory of health communication to organize data into 3 categories: knowledge, awareness, and intent. These categorizations were later used to develop audience segments. Second, in the forthcoming campaign, we're applying the principles of bounded normative influence. This approach focuses on the role of minority communities to impact majority opinion through location, frequency, and persuasiveness of messaging. The work revealed 3 general findings. 1 is the distrust of politicians and government intervention. 2, the lack of accurate health information. And 3, a desire for localized health information, meaning the individuals want to know what services are available in their community, and they also want to know how to access those services and find locally relevant answers to their questions. Also, several population segments were identified. 2 key segments were the traditional segment, who were not receptive to new ideas or innovations, and a transitional segment, who had some information about vaccination and were more active on social media. This traditional segment shared more information, and they were often linked to many individuals in that traditional segment. As a result, the forthcoming campaign will leverage the channels of influence within the traditional segment, and the information will focus on accurate, localized health information. Based on what we know about their proximity to those in the traditional segment, we anticipate that the transitional segment will influence sentiment across boundaries. Another initiative we've been working on at CCP is the CAP COVID survey and its affiliated dashboards. These dashboards present data from a global survey implemented in 67 countries. They cover knowledge, attitudes, and practices related to COVID-19 and vaccine acceptance. I highlighted the insights icon here, as this tool increases the interactive nature of the visualizations and provides data interpretation for all users, including global policymakers. To increase the utility of these dashboards, we developed user personas. Our aim was to tie each dashboard view to programmatic goals for 3 stakeholder groups: policymakers, public health officials, and WHO representatives. We developed visualizations by asking the question, as a member of a stakeholder group, what data do I need in order to implement an action? As a result, this led us to take a more journalistic storytelling approach to the data for these key audiences. RCCEs, or Risk Communication and Community Engagement Committees, are the coordinating bodies in many countries. They provide directions for COVID-19 prevention and intervention strategies. I've listed a few countries where our data have been featured in the RCCE meetings. There are others as well. Sharing these data is critical in many low and middle income countries because they often don't have the luxury of private research firms collecting national level data. The CAP COVID data has been featured in the global guidance documentation for the RCCEs. And just to show how these data trickle into national policy, it was through our Indonesian country team's work with the RCCEs and other stakeholders that the CAP COVID data is featured in the Indonesian National Vaccine Communication Strategy. Social listening doesn't always have to be social media based. This next example uses more traditional communication channels and is implemented in several locations. Community listening, also referred to as rumor tracking, is being implemented by Breakthrough Action in several countries. It's important to note that although social media opens up access to millions of people, there are many people who are left out due to the digital divide. As we know, having a handle on rumors in communities is important because rumors will negatively impact demand for care and treatment. It'll damage relationships between communities and their health services. It'll enhance divisions between groups of people. And rumors that are unaddressed feed into conspiracy theories. On the flip side, what is equally as important as tracking rumors is the facilitation of dialogue and participatory planning. This line of communication must remain open, whether it's a pandemic or not. Doing so fosters trust, facilitates early reporting, and increases confidence in public health information. This slide presents one version of a community listening or rumor tracking process that we are implementing. First, community focal points are trained to identify and submit rumors via WhatsApp. National hotline workers are trained to input rumors from callers and WhatsApp messages into a DHIS2 database. Data managers analyze and synthesize data. Periodic briefs that include social behavior change recommendations are presented to the RCCE committees. And the RCCE technical working group develops messages to rapidly address the rumors. This example uses WhatsApp, hotlines, DHIS2 databases, and technology like qualitative coding. There are dozens of ways to configure this work. Locally, you should use tools that work best for the team you have. And I'll finish up with 4 summary points in conclusion. So first, social media provides key insights, but it can miss the voice of communities that are often hardest to reach. Second, data should be presented in ways that consider your users' interests and goals. Third, integrate analyses that provide meaningful audience segmentation. And fourth, develop social community listening tools that are locally appropriate. Thanks for listening today. I hope you've got some of those links in the chat, and back to you, Tina.
Thank you, Dominic. I really appreciate that you took the short time to actually present 3 different approaches. And to me, at least, the takeaway from your presentation is also that really the integrated social listening and really looking at different methods that are most appropriate for what you need to research or listen to is really, really important. I also really appreciate that you highlighted the aspects of knowledge, attitudes, but also intent. And I think we really need to be looking more into the intent and what translates intent into action in people when we listen. So thank you very much. So I would suggest that we skip the Q&A session, try to go to the next 3 speakers, and then as much as possible, we'll prepare really short rapid fire questions at the end before we go to the keynote address. So I'd like to move to the last three speakers. The first speaker is actually, I understand, the recording. So I think Avijal is probably lining that up. So Avijal, whenever you're ready, please line up the video. Myung Cha from Institute of Basic Science and her reflection for us today. Go ahead.
It is my pleasure to present our work at this conference. I'm a computer scientist from South Korea. Korea, being one of the first countries affected by COVID-19, we were in a unique position to observe the birth and spread of many misinformation rumors. Here are some of the popular rumors that you have seen about COVID-19. Drinking alcohol can kill the virus in the body, or eating garlic ginger can help prevent the infection. You can find these rumors in virtually every language possible. What was surprising to us for researchers in Korea was that a lot of these rumors, when they propagated in many countries, had already been fact-checked and nobody would believe them in South Korea and China. There were some rumors that only spread locally. For example, fireworks can kill the virus in the air, or eating 9 eggs a day can prevent the infection. Not many countries have seen these rumors. Existing research has shown mechanisms of rumor spreading. For any rumor to spread widely, it needs to have the audience who will buy into that information. So this means countries where there are nearly 0 patients or very few patients were less likely to be involved in a lot of the rumor spreading. This also means that algorithms can help social listening functions and help spot rumors at a much earlier rate when we look at the time-space correlation across multiple countries. Another research has shown that when false information is fact-checked and when it is flagged, people are less likely to propagate that. So the picture here shows propagation tree of a Facebook single post, and red dots appear when somebody writes on the comment, this information had been fact-checked and it is false. You see less tendency for that spreading to happen after the red dot. Yet we do know repeated flagging is so critical because many people simply do not know whether this information had been fact-checked before. So taking insights from previous research, we came up with the idea that maybe it might be useful to find already fact-checked information from one country and translate and propagate that to another country. During March of 2020, when COVID-19 was really at the early stage, we teamed up with scientists and other researchers from South Korea and United States and launched a joint campaign called Facts Before Rumors. Our goal was really simple. We wanted to collect fact-checked information, fact-checked by the local CDCs in China and South Korea, because we already had so many different rumors by the time, and translate them into as many languages as possible, create easy to understand, beautiful infographic, and spread them before rumors even start to propagate in many other countries. Our campaign was received well. The infographic of the 10 fact checks had been translated into 20 languages, all by 50 volunteers whom we found on the internet and spread through Facebook, emails, Twitter, in 251 countries, reaching 50,000 shares. Now I'd like to share some of the findings from this very campaign. The first finding is about the prevalence of infodemics across countries. Our campaign was showing rumors along with fact checks and asked participants if they had seen the rumor before. This is how we are able to know rumor exposure rate of each country. And this bar chart here shows we see a higher rate of people who said they have seen any of these rumors in developing countries in the left-hand side compared to the developed countries in the right-hand side. This means that the very countries that are in greater need of the resources and infrastructure to combat the virus were being affected more in terms of exposure to infodemic. Our second finding is that when we examine the specific rumors, we found globally common patterns. Some rumors were really globally popular. The ones that we found were warmer weather will kill or weaken the virus spreading. Existing drugs can be repurposed to cure COVID-19. Yet some rumors did not have much say or standing in some of the other cultures. For example, the rumor about gargling can help the virus, kill the virus, spread more widely among the Asian countries. But the gargling rumor was not as popular in some other cultures. 5G rumor was the most popular among African countries and some of the European countries. Yet the 5G rumor was not so popular and people were not willing to spread it in Asian countries. So it seems like there's a lot of cultural preference for what kinds of rumors might spread better. Yet the 5G rumor, which was spreading really widely in some countries, had lowest believability rate. So that means simple exposure does not mean people are actually believing it. Our survey led to confirm that prior exposure to vaccines or having seen the fact checks or thinking COVID-19 is real were positively correlated with willingness to vaccinate. The most striking finding of our study was that having seen the false information and starting to believe it had the highest negative correlation to vaccination. So here are some takeaways. First, high exposure to misinformation does not necessarily mean people are believing them. So maybe what to fact check first can take into account these facts. Second, belief in false information seems correlated with vaccine hesitancy. And this means urgent actions are needed before any belief in misinformation sets in. Finally, detecting false news is not enough. Some preemptive measures, like what we have tried here, sending facts before rumors start to emerge, can be helpful. Thank you very much. I look forward to receiving your feedback.
Thank you very much for this talk. Andrew Pattison from WPRO Geneva, I see you're already lined up here. I would invite you to talk from your perspective. Please, welcome. Do you have a presentation?
Yes, I do, and I'm just about to share it now. Pleasure to see you again, Tina.
Likewise.
Thank you for the invitation
Great.
to be here today.
Please just maximize, and I think we're ready to go. Perfect.
Is that okay?
Go ahead. Yes.
Okay. Hi there. So I'm Andy Pattison. I'm lead of the digital channels at World Health Organization here in Geneva. And today I'm going to talk to you about two projects my colleague and I Javier are going to talk to you about two projects. The goal of the team is to get more health messages into more people's lives through more channels. And what we try to do is get into people's digital journeys rather than try to drag them into our digital channels. So we try to get into the 4 or 5 apps that you use on a daily basis on your phone, whatever they are. The way we do that is to focus on 3 pillars of work. Firstly, we raise good content. It's been said before by other panel members today that one of the ways to fight misinformation is to throw out a lot of good quality content. The second pillar of our work is to fight misinformation. And what we will do there is we will fight individual posts that contain misinformation. We will follow repeat offenders and try and get them off channels. We will actually look at entire channels themselves, and we will work with the policy teams in social media companies to improve their policies so that they can police their own content. The third panel is user insights, which is what we're talking about today, and the launching of new channels and tools based on those insights. So I'm going to talk to you about Google pro bono ads that we've received and how we listen to what's going on there to maximize the return on our work in that space. And then Javier will talk about Facebook Messenger. So Google ads, adverts which are placed across Google search and a lot of their inventory, help us identify content and allow us to place them. So Google have given us about $150 million worth of ads, and every month we burn through our allocation and they give us a little bit more. So it's really good project. What we'll do is every Tuesday, so in a few hours, I'll be sitting down with the Google Ads team, and we'll be looking at the trends about misinformation and the search trends which we see around the world. We will then identify quality content on the World Health Organization website, or if we can't, on Ministries of Health website, and push these adverts out to the users looking for that type of content. So what we're really interested in is listening to what's happening, and if that content exists, serving that content when people are searching for it based on the volume or the breakout trends, so the ones which are coming up in popularity, as well as the ones which have big volume. And if they don't exist, we work with our scientists to try to generate content to cater for these. And I'm going to give you 2 quick examples. I'm going to give you an example of what we saw happening in Latin America and Peru about a type of hydroxychloroquine that people were starting to search about. So we saw this breakout term. The team told us that it was a breakout term that was happening in these areas. We were able to identify it was a chlorine, a type of hydroxychloroquine. We were able to find where the rumor had started by checking out news. And when we looked in some countries, especially Peru, there was a huge number of and a huge volume of people searching for this as a treatment for COVID-19. So immediately within 24 hours, we were able to raise these adverts and display them to people who were taking those search results. So imagine the people making those search results are looking for search engine optimization results. Those will come at the top of the list. What ads allows us to do is to go at the top of that, right on the top of that list. Another example we saw was people heard about mass gatherings, the Olympic Games being cancelled, the football championships being cancelled, football matches being cancelled. So they understood large mass gatherings, but there was a lot of questions early last year with regards to small mass gatherings, we're calling them. So weddings, parties, and things like that. We were able to work with our scientists at the World Health Organization and put out content specific to those audiences and then serve adverts to those people. So what does this mean, actually? So far, the project has had more than 1 billion impressions. Sorry, there's a typo in my slide there. It's 1 billion impressions. And that's a lot of people, when you think about it, have seen our content. What does it mean on a daily basis? It means about 400,000 people per day, every single day, are being driven to our website. So that's it for Google Ads. I'm now going to hand over to my colleague, Javier. Javier, are you online?
Yes, hi there. Hi, thanks, Andy. So, hi, my name is Javier Elkin. I'm a technical officer in the Digital Health Innovation Department, and I'm talking to you today about the chatbot on our Facebook Messenger channel. So that you can see here on the left, it is animating right now. It should be animating on your screens right now. And the chatbot on Facebook is a tool that allows us to disseminate key information from WHO and went live in April 2020. So it's been around for the whole of the pandemic. It allows users to also sign up for daily alerts and subscribe to localized information from their country. And it can also show images, as can be seen here. And it is conversational in nature, which means that users can ask any sort of questions to WHO, and we include answers. So how do we use this for the infodemic management piece at WHO? Well, as you can see, users can ask all sorts of questions, but sometimes they may ask a question which we don't actually have an answer to, and this generates a fallback. And so what happens then is that, next please, we work with our technology partner, Sprinkler, who's developing this chatbot, to compile monthly reports based on artificial intelligence. They go through the 11 million or so messages that we receive and give us the top questions as different themes that we then look into. So the following step is to then assess the question relevance for WHO, because it may be asking things that are not relevant, but there are questions that we could answer that are maybe available on our website, or that we have the technical knowledge within WHO to answer these questions. And so we then communicate with the risk communications teams, and we propose some content that may be available on the website, or say, these are the key questions. Can you please query technical teams across WHO to provide an official answer? Then we receive the official answers that are WHO-approved responses, and then the official responses are then integrated within the chatbot, and we train the algorithm on these new expressions, and we send a notification text. So there's one more, please. Yeah, so we send a notification text like this that alerts all users that we've heard them, and we've compiled these answers, and we give them a list of questions with new information that we've added. And so all in all, this has led to over 45 answers being added to the chatbots in this way since the beginning of the pandemic. We're taking a data-driven, user-centered approach to adding new content, because there is so much information. We really cater to the community that is on this channel in this way, and provide answers to questions that are actually being asked, and not just answers that we could be answering, because we all know WHO has a lot of knowledge base. Thank you.
So just to finish off, these are just two of the 20 or so social listening projects that we have. We work with a company called NewsGuard that checks for misinformation across websites, which is where a lot of the rumors start before they appear on social media. And we have fact checkers who are looking also in so-called journalists' websites for those kind of content before it comes out. And happy to answer any questions at the end of the session. Thank you so much. Back to you, Tina.
Thank you, Andy and Javier, and also for basically yielding 2 minutes for questions later. So moving to the third and last speaker of the before the keynote. So Professor Neil Johnson from George Washington University actually spoke to us at the second Infodemic Management Conference last summer. And I understand you've been quite busy building on your work further. So we're eager to hear your update and your additional thinking. Welcome, Neil. Welcome back.
It says sharing is paused. I wonder if you can see my screen.
All is good. We can hear you and we can see.
Great. Okay. So I thank you so much, Tina. It's great to see you again. Great to see everyone again. I wanted to update, just to give an update of what we've done since last year. We published this picture of the ecosystem of the Facebook ecosystem. Hopefully you can see my slide. Tell me if you can't see the slide. And it was basically looking across the Facebook ecosystem, 100 million people.
So we don't see a slide beyond the title slide.
But you saw the title slide?
I think this is the first.
Yeah, this is the first slide. That's the second slide.
Yes.
So, okay, great. Thank you. So we wanted to deep dive into this. Of course, what a year to deep dive into this. Every red dot is a community that is quote unquote anti-vax. Every blue dot is a community that is quote unquote pro-vax, could be a public health, local, national, or global. Every green dot is something like pets, pet communities, parents. people who are interested in local schools, people who are not really interested in the vaccine debate, or who are not interested in the vaccine debate, but have somehow got entangled.
Sorry, Neil, I think we may need to just unzoom and just look at your slides, because we still see just the start, but we don't see the network map.
Come out of presentation mode.
Yeah, maybe you need to just come out of presentation mode and just present in a less pretty way.
There we go.
Perfect. Now we see.
Great. Okay, great. I'm so sorry about that. And the greens are communities of pet lovers, parents, school associations, everything you can imagine, other than worrying about attacking vaccines, attacking public health messaging. That's what we had last year. And so the question is, well, what happened during 2020 and what is happening now? So that's what I want to share with you. One of the things, since we take this system level view of the entire ecosystem, we can answer questions that maybe other approaches cannot. And I just want to take you through the 5 things that we can answer here in my 8 minutes left. Number one is, it's really interesting to see during this year where moderators have actually missed communities. I mean, which segments are missing from having CDC messaging, et cetera, et cetera. And so it's very interesting that if we look in, we zoom in on that entire ecosystem. Basically, Facebook has done the equivalent of throwing kind of arrows, shooting arrows, throwing darts at the center of this universe. And what it's missed is these entire sets of communities, of which are, you're looking at ones, the dark ones are ones that have been targeted. The lighter ones, which are all the greens and most of the blues and many of the reds, are ones that have not. So they have not received targeted messaging, CDC messaging, et cetera, et cetera. And there are entire communities of communities that have are focused towards, for example, parenting or illnesses, et cetera. Just move that around there, that have been missed. So I want to zoom in on that for the moment. First of all, what is the shift in that entire ecosystem during this year? Well, last year, just as COVID was hitting in December, this is what that looked like. And on the bottom right, I haven't got time to go through it, it's all the segments, all the individual audience segments of the individual undecided, in other words, the kind of the communities that are embroiled with anti-vax, but are really not saying they're anti-vax. They break down into all sorts of categories: movements, illnesses, parents, conspiracies related to chemtrails, et cetera, et cetera. This is where they're situated. And if I flip to the end of 2020, and if I do this quickly enough and you can see it, just about see it on the screen, you can see that this thing has actually kind of tightened up. This entire ecosystem has tightened up. And so the question is, well, what does that mean in terms of how messages have passed across the ecosystem? And what are the key communities holding this thing together? What's the glue? What are the communities that are gluing together the local, national, global, 100 million people that are embroiled in the vaccine debate and COVID misinformation? On this slide, I show how as the community, as this ecosystem became more, just get this thing running, as this ecosystem became more tighter, it bound together, it's almost like a chemical bond. It enabled misinformation to spread, also positive information, but here you're looking at misinformation about COVID spreading throughout the early weeks. This is a week by week judgment analysis. This is why it's so hard to get answers as to, does false information spread differently from true information? Which spreads more quickly and what can it's all sorts of answers. The details here, we could talk a couple of hours just about these slides. But the problem is that it's complex. But the point is it passes on roadways and among communities that are bound together. So it's not so much the actual material that's passing, it's how those communities in the ecosystem are bonded together. And it's really interesting, this is getting onto the next angle that our analysis this year of the ecosystem has shown, is what are then those key audience segments for spreading that misinformation? Of course, if you go in and look at individual misinformation, you're probably going to find it's like doing a case study. Here we're looking at the entire ecosystem. And so what you see here is I've zoomed in on, if I just show here, I've zoomed in on one region of this entire Facebook ecosystem, which has, as I said, about 100 million people. And I'm zooming in on a region which was not targeted by Facebook, did not get public health messages. And if we look at this on at first sight, when I just zoom in on the left panel, you might think there's a whole set of pink here are, I mean, they're all green communities, but I'm just running out of colors. So the pink ones here are communities of people online who are not really, they're not talking about COVID per se, they're talking about chemtrails, they're talking about 5G networks, they're talking about other conspiracies that have been around for a while. The green here, shown here, are ones that are really targeted towards food, GMO food, genetically modified foods, etc. And the black communities shown here, the color black here, are in some sense all of us, the parent communities. These are the ones that are interested in kids' soccer, they're ones that are associated with schools, their school activities, their parenting communities, how to raise your kids, what happens if your kid has this, your kid has that. These are the communities shown here. And at first sight, it looks like the bonding that has happened between end of 2000, in other words, during COVID, looks like it was pulled together by the kind of GMO. I mean, if you're looking at this in a kind of chemistry test, you'd say, oh, it's the GMO communities and the existing conspiracy communities that have pulled themselves together closer to the parents. But that's not true. Actually, there was another set of communities, which I didn't show in the previous slide, which are the alternative health. And so what our analysis does is enable us to go in and drill down at the granular level of exactly what angles of alternative health have provided the key conduits of information, misinformation, that are worrying the parents. And remember, the mainstream parents, I mean, it's all of us. Parents have kids, kids have to go and have vaccines, parents have parents, if they're still alive, and they had to go and have vaccines. So parents have a very influential role. I'm just zooming in on parent sector here, just for the purposes of the discussion. And what we found in our analysis of 2020 is of that entire ecosystem, there are two key pieces of misinformation machinery that controlled all of the misinformation that we see across those 100 million people. And that is, number one, the alternative health off to one side. They're kind of above, sitting above the parents. And then within the reds, within the anti-vax, there's this core of a few low profile communities, in the sense they don't actually have that many members, but they're incredibly highly connected. Doesn't mean they're hubs, it just means they have a high betweenness in terms of the community. They're like conduits. They're also connected into other platforms, et cetera, et cetera. What does this mean? What does this give us? Well, this gives us an angle on understanding the tipping points in intent. So if I now take a block form of what I was previously showing with the 100 million, with all those different communities, all those different blobs, each of which is a community, and we block them together into communities, we can begin to see the influence. And these numbers here are links at the level of one community to another. It's a community that has purposely linked itself into another community because it wants information from them. It's going to get feed from them. All its members, 20,000, 2 million, will get feed from that other community. And so by now having numbers for the links between these different segments of the audience, of the audience that were not targeted by, they're not getting other information from public health, already showed that they lay outside that target area. We can begin to model and understand what their tipping points will be in the future. I haven't got time to go through all that detail. But Facebook, of course, is just one platform. People have said that. Fantastic talks today, by the way, everyone. We look at this same thing across platforms. So imagine this across platforms up to, even including Discord, anything where communities can form. And the communities can form around radio, they can form around TV, they can form around anything. and we see how they connect into each other. And that gives us an idea of that entire ecosystem, which we call a multiverse. Sorry, I'm a physicist, so I have to use words that I permit my limited vocabulary. So what this gives us is an analysis that effectively includes more than 1 billion people. It's all languages, countries, and platforms. It tells us what moderators are missing. It's telling us about shifts, the bonding in the entire online community, online world, multiverse, from local, national, and because we can localize this down, local, national, global. Shifts in that, how the spreading then occurs, which segments are the key ones that are missing, and the ones we're bonding. There's no point targeting communities that are not holding together. I mean, of course, in an ideal world you would, but you really want to know which are the key ones in terms of the glue holding together the whole, the entire population of the planet in some sense. So my last 3 points, this is beyond sentiment analysis. This isn't based on just looking at keywords, and it's also beyond any kind of AI machinery, because what we're doing here is really generating, you have data, you have machine, some kind of, I call it machine learning, some kind of algorithmic approach, but you also need generative models. You could never build a picture of the solar system just on machine learning. It needs to have some kind of structure behind it. So we build these generative models that make them this triangle for understanding the system. And it's beyond social listening in the sense that we're not just listening to what has been said, we're looking at the structure of the communities about what they will likely say, what they might say, what could happen when version 2.0, 3.0 of the different vaccines then comes out. Okay, with that, thank you so much.
Neil, thank you very much for this update. I think your team absolutely deserves one of the commendations for working towards fulfillment of the grand challenges of the public health research agenda for infodemic management that we formed last summer, because these were the hard questions that we were grappling and identifying as knowledge gaps in understanding the analytical approach to being able to understand this such complex problem. And in a very short amount of time, I think you've really laid out and showed how it's possible to, like you say, you go beyond the actual computational method and you really look at the multiverse, which, by the way, my sons would be very happy to with us naming something like this going forward. So really thank you for your work and also for presenting this. So I'm mindful that we have 5 minutes left, and I actually really I'm sorry that we won't be able to ask all of the speakers the questions. I would rely, Chris, on you to also facilitate this further and a discussion with all of the experts that are with us today also after today's event. So I will call out only 3, and I would ask you to please try to be brief, because after that we will go to the keynote and conclusion of our event. So I will be calling on Joe from UN Global Pulse, on Andy Pattison from WPRO, and Neil Johnson that we just heard. So first over to Joe. This is a bit of a synthesis of the questions that are in Zoom. So, we use community radio to reach people in remote areas and in resource-constrained communities when we're doing communication, also, in and outreach. And usually this community radio covers the non-digital community. Do you think we could use this social listening tool from UN Global Pulse and WPRO then to help assess engagement with radio messages? And what would that look like?
Thank you. I think that's a really good question. And yes, as you said at the beginning, I think we think of this as sort of an offline community, but appreciate that there's also an overlap between this community and who do use online sources. So I think the first thing would be understanding what percentage of people we're getting extra or additional reach with from radio, which is the hard thing to assess, but something that we could look at assessing and would be good to assess is what additional reach we're getting from radio. And then I think as we have a lot of these transcriptions now, or we're working towards transcribing a lot of this audio, and we can use a lot of these textual-based techniques that we've looked at and other people have presented so far, we can look at seeing how we can translate those into the sort of radio monitoring domain to try and also monitor how we can look at the stories and opinions that are being shared on radio, and how the WHO can use some of their current intervention techniques and developing intervention techniques in this stream. But I think we'll need to work towards developing or adjusting some of the tools. So I think one of the things we've learned is that there's a really great set of NLP natural language processing style tools that we can use for analyzing social media, but they do need some translation into the radio domain. But something we're also quite interested in is looking at how information passes from one platform to the next. So based on actually some of Neil's research that he just presented, which is really interesting, could we apply this in the radio domain? Could we look at, for example, when WHO makes a public announcement, how do those get translated into the news? How do they get translated into the radio domain? How are they talked about in that domain in contrast to the other domains on social media? And is there an overlap between these communities or not? And is there a lot of synthesis or not? I think that's something to look at that will be really interesting in the future.
Yes, thank you, Joe. I actually think that the cross-platform jumping of information is also could also be used for signal detection or evaluation, because what we've seen also in the field is that when misinformation or pieces of rumors actually start switching, that potentially could be a way of assessing the criteria for responding to it. So I think that's great. It's really great to hear. Thank you very much, Joe. Over to Andy. Lots of questions about different aspects of WHO work with tech companies. And so people are asking about your view about the effectiveness of partnerships with tech companies. But certainly there's a mix of challenges and opportunities. And how would you respond to that?
Well, as I said in the Q&A chat, it's a mixture of the good, the bad, and the ugly. Or as one author said, it was the best of times and it was the worst of times. I think that what we've seen is that there is a humanity and solidarity which has come out, which hasn't existed before, especially with fighting anti-vax content. I think that the tech companies have responded fairly well on the whole, and we can't honestly do our job without them. Some of the ones which have really responded well, such as Google Search, have allowed us to surface our content in an organized search result panel. So what you'll get when you go to Google Search and search for COVID or coronavirus or 30 related terms in 80+ languages is you don't get just your normal search results page listed on search engine optimization ratings. What you get is an organized panel. So you get WHO content, you get your local Ministry of Health content, and you get accredited journalists' news. That took ages to pull together, but they were very swift at doing it. The final result now is probably about 10 or 15 iterations of that. That was a really important thing. And if you think about the Google ecosystem, outside of China, that's still 80% of entry into the internet is through Google Search. You're looking at between 200 and 300 million eyeballs a day on that content in the Google ecosystem. So a huge amount of traffic and content has been surfaced and traffic has been generated. We've had good relationships with Facebook and Google and Twitter and a lot of companies, TikTok, to improve their social media policies around misinformation. And we've worked with the policy teams extensively, 2 or 3 times a week in the case of Facebook, 2 or 3 times a week in the case of Google and YouTube. And what we do is we try to show them the problem definition and encourage them to find solutions to their problems. These are their channels. They have to take ownership. YouTube came out fairly early on to say if it doesn't meet WHO guidelines, then the content will come off. Others have said that, but not been able to police it. I won't name them, but some, if you're on the app and you flag content, it invariably comes back and says does not violate community standards. Even though the policy is in place, no one is there to police it. So I would say it's been mixed results. There are some companies that literally only woke up in January this year after I threatened to go public on how terrible we thought they were. But overall, I think that this relationship of public and private partnerships is super important. And with our great content, and ours being WHO, the health community, the ministries of health, and their reach, that's the only way we can reach things. We can reach huge populations. And the way I've always done it is, as I've just said, paint the problem definition and let them try to find the solution definition. Over.
Great, thank you, Andy, for this as well. Definitely the partnerships with the tech companies are really important. We're probably going to learn a lot, just like on other aspects from the last year on how to work together further, also through your work. Okay, last question for Neil before we start concluding. Your analysis is really interesting. What have you seen as early signals of tipping points for tightening and clustering of communities that are sharing the harmful narratives about vaccines? The reason why I'm asking is because are you seeing many brokers as connection points between communities that could help us to expand the reach of helpful information to some of the more distant communities that it's that are harder to reach? How do you think we could use this information, or do you see patterns that we could already be thinking about?
Yeah, great question. Two aspects to answer that. In the existing communities that are already anti to some degree, a lot of them are now, the early warning that they're becoming this kind of high-betweenness, they're the ones that are going to become the glue, is the spread in their administrators globally. So, you might find a small community up in Saskatoon in Canada that suddenly picks up administrators in Australia and the UK. That's ones that are already, though, on the, they're already sort of anti, getting towards anti. Among the ones that are on the fence, it's really interesting because most of the time they're connected in, but then the parents, they're not talking about, they're talking about the sun, they're talking about, nice landscapes, they're talking about problems they have with their kid, they're talking about homeschooling, they're talking about all sorts of things. They're not actually talking about vaccines or masks or what they should be doing. As soon as they start talking about that, as soon as those first words appear, those words would not appear on any word search. They're just being used, for the first time, really, in the community, buried underneath the posts, underneath the comments, in the replies. You start to see it emerging. That's the early warning sign. How do you pick that up? You need the map. You need to know where to look. Otherwise, you're just saying who mentions, masks for the first time when they haven't before. You'll never find it. With any kind of machine learning or AI approach. You need to know the map. And so, sorry, it's a long answer, but those are the two things. One, on the side that are already on this, moving over, they begin to get a structure in their administrators. These administrators are not well-known people. They're not the high-profile people we necessarily think about. Those communities tend not to be highly embedded. They're almost like standalone islands. They're big, but they're standalone islands. They produce a lot of material, but they're standalone. The glue is the ones that are under the radar. And then on the side of the ones that haven't yet tipped, it's really buried deep in the replies is where they start talking about it.
Thank you. I guess we're seeing, what we'll need to do is start merging some of these analytics further in order to be able to make tools that are then really actionable and deployable in public health response. But this is really an interesting conversation. I wish we had more time. I also want to acknowledge, I saw that Dr. Myun Cha is online from South Korea. And I wish we also had the ability to and time to speak with you. And I really wanted to thank you for being with us today, and hopefully we can engage further also in the asynchronous discussion on Zoom. So this brings us to the conclusionary keynote. We're kind of doing things backwards, just like we do in infodemic management. We're looking at all of the different things that we're working on, and now we try to bring all of the threads together. So that task is coming to Jess Collis from US CDC, and really welcome to deliver a keynote on social listening on this, and we'll then have a very brief 5-minute Q&A with Jess. So please do submit questions, and we'll try to get 1 or 2. Jess, the floor is yours. We see your screen, and welcome.
Thanks, Tina. As Tina said, my name is Jess Collis. I am a health communication specialist on the demand for immunization team in the Global Immunization Division at US CDC. I've been deployed full-time for a year working on the COVID-19 pandemic. I have worked on our Joint Information Center social media team, supported the 2020-2021 flu vaccination campaign, served as the first social media lead for the vaccine task force, and now serve as the co-lead for our insights unit on the vaccine confidence team. Even before we knew what we know now, back in late December 2019, in my old day job, where I managed social media and the CDC flu Twitter handle, I began to see our handle getting tagged about reports of mysterious pneumonia in China. The tagging only intensified, and I was actually tasked to pull notable tweets to send to my supervisor, in addition to my daily monitoring for flu-related conversations. Little did I know, did we all know, that we were facing the beginning of what we hope is a once-in-a-lifetime pandemic. After the COVID-19 pandemic emerged, media consumption in the US increased by 60% compared to 2019. Screen time averages for adults spiked to over 13 hours a day in March 2020. Many Americans reported feeling overwhelmed by the amount of information on COVID-19, especially as they were spending more time on screens than ever before. Constantly changing public health guidance and mixed messages from authorities also contributed and continue to contribute to a noisy, crowded information environment where it can be difficult for an individual to identify what information is not only accurate and credible, but also fresh and valid. How can you know what you are retweeting or sharing is still right? Why would you not share that post about a danger so your friends and families know to avoid it? Misinformation spread during the COVID-19 pandemic here in the US has led to increased calls to poison control centers due to the misuse of household cleaning products, ingestion of bleach, and improper use of hydrochloroquine. As the pandemic has progressed and vaccines came into the conversation, misinformation began to spread about COVID-19 vaccines too. Organized anti-vaccine groups have taken to collecting stories of individual tragedy and using them to convince others to see themselves there and to join in their fight for what they call medical freedom. Where high vaccine uptake is essential for us to move closer to the end of the COVID-19 pandemic, maintaining public confidence in vaccines, vaccinators, and the health system is critical. Addressing the COVID-19 infodemic and the misinformation around vaccines is paramount, given the critical issues with vaccination on a national and global scale. Misinformation about COVID-19 vaccines is especially concerning as it seeks to polarize the topic and exploit people's and communities' fears and distrust of governments and health systems. It also makes it difficult for people to find, distinguish, and act on credible information. However, chasing individual pieces of misinformation in attempts to debunk them ignores the real, larger social and cultural forces that cause these pieces of information to emerge and gain traction in the first place. Understanding themes of misinformation and information gaps that exist, and then developing programmatic communication approaches that address these underlying narratives is critical to better addressing the challenges of the infodemic, and is especially important in my work to promote vaccine uptake here in the United States. As I said earlier, I have been deployed in a few roles on the COVID-19 response. My most recent role, co-leading the Insights Unit, came out of a need that developed when I was the social media lead for the vaccine task force. I was facing my own personal infodemic. It was difficult to balance being responsive to the information gaps and misinformation I was seeing spread online and the outpouring of new content from our task force, while also trying to balance the message fatigue that consumers were facing. Social listening tools that we have. We've seen some great new ones today that are more appropriate, but social listening that many of us have access to now are not built to help us track and recommend actions around public health crises. So after many late night brainstorming sessions with Liz Wilhelm, our Insights unit was born. Our Insight unit is currently staffed by 2 co-leads and 3 to 4 full-time analysts. Our key product is our bi-weekly COVID-19 State of Vaccine Confidence Insights report. The report looks at multiple sources to help us better understand the communication landscape surrounding COVID-19 vaccines. To develop the report, we look at social listening data from our social listening tools, as well as hand search closed network and social media platforms. We analyze comments on our own social media channels. We monitor stories in the media and track the media requests we see coming in, review current polls and new research published in peer-reviewed literature, look at research and polls that we're doing ourselves, analyze calls and emails into CDC's call center, and track web metrics. After collecting and analyzing each of these inputs separately, our team comes together every other week to triangulate and synthesize what we are seeing. This is especially important as it allows us to weed through the noise and figure out what major themes are rising to the top in this hectic digital landscape. Our process has become more streamlined with time, and we are now better able to identify emerging issues before they become major themes. This work is part science and part art, as there is no way to determine what necessitates a threshold for a theme or emerging topic. After review all potential themes, my co-lead and I review all of the team's notes and put together an outline of themes, emerging topics, and continuing topics, and circle back. From there, our team determines the threat level of each identified theme as it relates to vaccine confidence. We are currently working on a code book in order to make this a more formalized process, but as of now, we've had 4 levels emerge for us to code and provide context to our readers. We look at each theme and determine whether it's high, moderate, or low risk, and in some cases, whether it's positive sentiment. High risk, we focus on items that could lead to vaccine refusal directly and will directly affect the uptake of vaccines. These are also themes that are typically have a wide reach and are pervasive in the digital environment. Moderate risk may not have that direct initial reaction, but will trigger hesitancy, and they tend to not be as widespread as high risk. Low risk, they are items that are concerning and could have impact on vaccine confidence overall, but are typically reserved for themes that are not widespread or have an impact that may be limited into a smaller subpopulation. And our newest addition, as I said, was positive sentiment, which such far we've only been able to use once, but allows us to highlight when positive themes are just as pervasive as themes that threaten vaccine confidence. After this, our team considers the directionality. We look at conversation volume, share of voice, and percent change from one report period to the next. This is helpful for context to allow people to see whether these conversations are on the rise or have remained stable over time. But as other topics have fallen in prevalence, a particular theme is now standing out. Our team then pulls all of the appropriate information into one place so my co-lead and I can write narratives. These narratives synthesize all of the data and showcase the perceptions of COVID-19 vaccinations and how they might impact confidence. However, what makes our work different than typical social listening and media monitoring reports is that alongside the narratives for each identified theme, we share ways to take action and address the information gaps, perceptions, and rumors that may have led to these themes emerging in the first place. The ways to take action typically fall into 3 categories. First, communication. What content or information is missing? What messages do we need to disseminate or amplify? What messengers do we need to work with to do that? Second is programmatic. What can we do to improve upon the issue? Do we need to create a website, identify a new process or system? Is there a particular barrier that we need to address? And lastly, research. What do we still not know that we could learn from a survey, focus group, or a listening session? What do we need to know in order to produce better communication and programmatic opportunities? This is the most important part of the report. At the end of the day, we want to report to find its way to people on the ground who can quickly take action. At CDC, we have a direct link to our communications team on the vaccine task force. They take each of our communication recommendations and break it down into actions to improve our agency's communication efforts. From putting together a prepared response to a question that has emerged or a misperception that has grown, to expanding web content, to informing our social media editorial calendar, we have seen this report directly impact our task force communication efforts. With our distribution list growing by the day, the overwhelming feedback we receive is that this paints a picture that not only validates what many people are seeing or hearing anecdotally, but that our ability to find misinformation and perceptions that are in the middle of the pack and highlight them helps health departments and organizations know where to focus next, what the needs are going to be, and focus more towards social inoculation space we need to be in. Since the report began, we have seen a conversation shift and change drastically. Our first report heavily focused on frustrated consumers, how frustrated consumers were with the state and jurisdictional eligibility and the lack of clear communication about who is eligible for vaccination and why. However, the groups who were eligible were facing systems that were difficult to navigate or were not able to handle the high volume and demand that did exist. We even saw the beginnings of conversations related to the impacts that virus variants may have on vaccination efforts, which, coupled with a large need for better education around what vaccine effectiveness numbers meant more generally, was particularly challenging. We also saw the beginning of confusion about maintaining mitigation measures after vaccination and confusion about what we did and did not know at the time about asymptomatic transmission among those who have already been vaccinated. This was especially challenging as it began to make many people think that vaccines were not a path out of the pandemic and into normalcy, and challenge the benefits of vaccination, which for many is the most powerful internal motivator. The confusion about vaccine benefits continued into our next report, where we were seeing people more confused about whether one shot might be enough or they needed two, or did previous COVID-19 illness play a role in whether they needed to be vaccinated at all, or did they just need one dose? With new studies on vaccines coming out, what feels like daily, research findings and official recommendations were getting lost in translation, and consumers did not know where to turn or what they needed to know. By report 3, this led to us seeing conversations about people wanting to mix brands of vaccines in order to increase their effectiveness, even though that's not how it works, and people begin to even start shopping for particular brands that they thought would be best for them. And now at report 6, we are seeing the beginning of vaccine supply exceeding demand in the United States, which has triggered conversations about hesitancy, and that has become front and center on all media outlets. However, this was different than before. Their messages now are on how demand issues may make population immunity impossible to reach, which makes vaccination seem not to be a viable option to return to normal, which goes back to where we started. I'm not going to lie, this is a lot of work. There is no silver bullet. It is also an imperfect science, and one that is very much in its infancy. We were able to recently test our system with the pause of the administration of Johnson & Johnson Janssen COVID-19 vaccine was announced in the US in mid-April. Using our same methodology, our team did a rapid insights report over a 3-day period that focused on understanding consumer perceptions, concerns, and the overall threat that that pause had on vaccine confidence. We also unpacked content gaps that emerged the day of the announcement and following the CDC's advisory board meeting a day later. And then what information was then also being spread as a result. Since the target audience for this rapid report was our own federal agencies, we laid out directly what the US federal agencies could do to reduce the impacts of the pause on confidence in COVID-19 vaccines. While this was not easy or quick, the process we followed was the same step-by-step process we do for all our reports. It showed that the mechanisms we have put in place allow us to act quickly if there's an immediate event that needs monitoring or a pulse check. And we know that creating a robust system is essential for us as we build systems that can do this work far beyond COVID-19. As we all build out our systems and work together to build better systems, it's important that we focus on how to build a system that is robust and sustainable. This work is not going away, and I know I'm preaching to the choir. It's only getting larger as our digital world expands, evolves, and becomes more complex. But it is possible, and our ability to reduce the harm and misinformation because of all this work is worth it. Thank you all so much for your time. If you are not receiving our COVID-19 State of Vaccine Confidence Insights report and you would like to, you can email, I have it on the screen, eocevent515@cdc.gov. I really appreciate the time today and excited to take your questions.
Thank you, Jeff. I'm already composing the email to subscribe. This is great also to see what this type of analysis and insights actually look like in action. It's really inspiring to hear about the work of your unit and how this has been also established and institutionalized at CDC. Here's more of a broader question for you. What advice would you give to public health teams, and some of which may have only one infodemic manager, but they need to triangulate different data sources, both to develop actionable insights and then also to help evaluate response? And something that came up earlier in our discussion, was this accountability to affected populations. And what kind of advice can you give as juggling all of these responsibilities and providing actionable recommendations?
Yeah, I think, well, the first place to start, I would say, and where we started was we sat down when I began this role and laid out all of the different inputs that we already had that already existed. And we had many groups already doing media monitoring. We had a contract for a group to do social listening and media monitoring for us. The US CDC has a social media team that does analyze their comments. So when it was there were only three of us, two of us by myself in the beginning, and we sat down and looked at all the inputs, and we began to figure out what would be the best way for us to go through each of those inputs individually and how we would use them. And so that was where we started. And I think that is completely a reasonable effort to begin your work. What I think is important and what's overwhelming, especially in the beginning, is that there is so much. However, what we've found now that we've gone, and we've been doing this since early February, put out our first report, is that once we got that initial analysis done and a lay of the land, it became easier and more systemic to look, to monitor what was happening and monitor the conversations online and how things were spreading, because we knew what the landscape generally looked like and we didn't have gaps in weeks. We were able to more quickly identify things that were emerging and put out recommendations. From a recommendation standpoint, I think, especially if you have a small team, that's where you need to leverage relationships with a communications team or people who are doing the implementation work or researchers who are doing the research. Identify those people who can help you think through what actions you could take. And even if you have general recommendations, that's better than none. I think the challenge with a lot of the reports we were receiving early on is they were just saying, there's this misinformation, and our leadership was looking at it and saying, we have to address this, we have to fix this, but no one took a breath to really look at what the problem was, which in many cases was that people didn't understand how vaccines work. They didn't understand what the benefit of vaccination is. So we really had to teach people to really analyze what they were seeing from a mis and disinformation standpoint and really look at what the content gaps were and what actionable things we could do that wasn't just debunking or flagging something to be removed. So I think you have to think pretty creatively. I think risk communications is a great foundation for identifying ways to take action. I think also just making sure you have, even if you don't have a team doing this work, you have a support team that can help you identify the best ways to move forward based on your group.
Yes, thank you. I was thinking as you were talking about that, basically anyone that's doing infodemic management will be a victim of their own personal infodemic in the evidence that we collect or get exposed to as well. And in the search for to have evidence-informed insights, sometimes there's the culture of having so much data actually overwhelms then the dialogue with the practitioners. So I'm curious, you know, that's a bit like having to do culture change with the counterparts that have other professional backgrounds, or, you know, the other day jobs. Any thoughts on this? Like, how have you tackled that? You know, not everything needs to be responded to, even though we have data on it.
Yeah. Well, first of all, I hate to say it takes a lot of meetings. I have a lot of meetings, and so does my co-lead. We actually divide and conquer many of them. But early on, and even now, we have a lot of conversations about the work we're doing, and we are working on a formal methods document, which we would love to share once that's cleared. That would help people better understand. We received a lot of pushback as far as the science behind this work and how we are identifying themes, and whether or not it's, you know, are we making mountains out of molehills? And, you know, luckily we have a deployer come into our team who has a background in methodology for quant and qual, and she was listening to the work we were doing, and she's like, wow, you follow a very clear method-based approach. And so she's independently doing a review of our work to help us finalize this methods document. But I think it's having a lot of conversations about this work and what the needs of people are. I think it's, as you said, it's a lot of people, especially who are not in the day-to-day of listening to the environment. They're overwhelmed too. We're all overwhelmed with the amount of information. So it's about identifying what information we can act on. And I think also teaching people the value of this work, because at the end of the day, having just one or two people in a country to do this work, or in a region or in a continent, is not reasonable or where we need to go. We really need to make sure people understand that this is a science, that there is a lot of work around it. There are very clear methodologies, but that debunking is not going to fix the problem. So we've had lots of conversations about social inoculation, and identifying content gaps. And that was particularly prominent with the Johnson & Johnson Janssen COVID-19 vaccine pause here in the United States, was that everyone wanted to jump on debunking the misinformation. We were like, well, the bigger issue is all of these questions, and that we don't have answers to these questions. So we need to come out both saying we don't know these answers, but then also do our best to answer what we can answer, before we worry about addressing, what, influencers in the vaccine denier community are saying, because, their reach is, while they're loud to us, their reach isn't as far as people do think. But there's a lot of people in the wait and see who have questions, and genuine, authentic questions, that would more likely delay their vaccination than seeing something that a viral anti-vaxxer would.
Yeah, thank you. It's really inspiring. I find it great to see how we've actually, through these conferences and other types of projects, that we're really starting to make connections and share experience, because what you're describing is it's great. It validates a lot of other experience, and I'm pretty sure that others are nodding as well. What we just need to, as a community and the practitioners that are developing this, we need to make sure that we keep sharing experience, and that this now translates into tools and methodological work, just like you're saying. And I really look forward to hearing more about what your team learns as you go along. I would really like to thank you for sharing your thoughts with us. It's quite inspiring. Yeah.
Thank you.
So we are 1 minute over, but I think we can conclude the session today with a really brief, maybe reflection, and then housekeeping with Chris. Yes, I will take the liberty of moderating the session, just to reflect really on how inspired I am with all of the contributions today. I really feel that we've experienced quite a surge and coalescing of various activities and different tools and expertise in infodemic management and in social listening. and in the health system and social response to the pandemic. And these talks really show that. But we're also seeing bridging of the practices. So my background is informatics and analytics, and human-centered design that used to be a digital health and technology practice is now incorporated into design of public health interventions. And at the same time, experience from health communication is crossing over into data science projects, and we saw and we heard example of this. So we're really starting to see the building blocks and components of what capacities are needed to respond to the pandemic, and then also to support the recovery in countries. And one thing that we were discussing all last year at several of our conferences when we came together as a community was that public health and epidemiology, they've both experienced growth spurts. As we were experiencing new diseases or public health challenges. So we learned about the importance of community engagement from Ebola response, and we learned about the importance of the work with hidden communities during the HIV epidemic. So in the past year, we've experienced an unprecedented challenge for our health systems and public health systems, but we've also built on existing practices and come together to fill in gaps and cross-share the knowledge and experience. And I think today's discussion is quite an example of that. It's really been, infodemic management or now social listening has really been recognized as an important part of a policymaker's toolbox. So during the session today, in conversation with Neville Kalea from Ministry of Health Malta, we reflected earlier that really we're experiencing revolution both in health communication and in health promotion. And we're really moving from a monologue that's delivered through a megaphone to the public and really moving into an intelligent science that's delivering effective communication interventions. And both on based what's worrying communities, and that's social listening, and also based on what is weakening the population, and that's based on health information, which is bread and butter of public health policy making. So we're really starting to see this connection between public health monitoring and health information analysis, and then complemented by social listening. And this is, to me, really a start of a shift in public health systems and capacities that are added to the evidence-based practices and evidence-informed policy making at a Ministry of Health or in a health authority. So in this sense, we're really seeing the start of what will make infodemic management methods and toolkits and practices sustainable and integrated with health system preparedness and response. And this is really inspiring to me. We as a community and practitioners have really come a long way the last year. So really my personal appreciation to you, and before we thank also the organizers and the team that has helped us come together, I would go over to Chris just to remind us, what's next. This is one of the first session of several for the conference. Please guide us through what happens next.
Okay, great. Really delighted to hear everyone's case studies shared today. What a fantastic start to the conference. And I think now that we've got a better sense of the landscape in terms of the wonderful work that everyone's been doing in terms of social listening, now I want to issue a challenge to us. So day 2, which I encourage you all to register for, and the link will be dropped in the chat. This is where we're really going to challenge ourselves to look at what is the next generation of tools and techniques that we can try and apply to advance our social listening programs for public health. So please make sure you register for that. It's 11th of May, starts at 12:30 Central European time, and there are limited spaces. It will be live streamed as well, but to be able to participate in the live Q&A, really important that you register to snag a spot. And then after we've delved into some exciting advances to level up our social listening on day 2. We're going to come to day 3, where we bring it all together with a panel discussion, delving into some really challenging topics. You know, how do we handle the challenge of dark social? What are the ethics of social listening that we need to bear in mind? What are the opportunities for us to strengthen our collaboration and coordination going forward? So the really exciting agendas for the day 2 and 3 to come, and encourage everyone to register and return, and let's keep this conversation going. Certainly one of the goals here is to foster an ongoing community of practice of all of these experts. So thank you very much for your participation here today, and back over to you, Tina.
Well, really what remains for me is to thank first the team that has organized this. So thank you, Chris and Jaya and Lynette and Avijal and Kat for really organizing this. I'd like to thank WPRO and Sylvie Briand and Tim Nguyen for really chaperoning this vision, working with partners and really championing this growth spurt of an infodemic response over the last year. And, you know, the challenges really, I know that this conference is not over, but the challenges, please, in 4 months' time, I need to measure my time. We need the 5th one. I'd also like to thank all of the speakers and the interpreters who have been working really hard to get the keep our conversation going. So I look forward to the other 2 sessions in building the infodemic management toolbox in social listening. With 9 minutes overdue, I think we're actually quite good on time. Thank you, everyone. Thank you for all the questions, and see you very soon, 11th of May. Bye, everyone.